the Lupus Foundation of Jamaica. So thanks again, Dr. Tullereed, and indeed, the symposium is now open. I just want to indicate that there will be 4 sessions in this symposium, followed by a panel discussion, and of course, we'll have a question and answer section. And believe me, that section is usually very vibrant, and I do encourage you to try and be here for all of the sessions, including the panel discussion and the question and answer section. I would also encourage you to have your little notebook handy, because when speakers like Dr. Stacey Davis, Dr. DeCula, when these esteemed medical professionals, and of course, Dr. Iris Milan, come forward, you'd want to ensure that you have the necessary notes. So, at this segue, we will begin what is session 1. And of course, session 1 will be kicked off with the introduction by Dr. Stacey Davis, our consultant rheumatologist, and she was also a former president of the Lupus Foundation of Jamaica. So, of course, and she's very much involved in many of the programs and the symposium committees. So at this time, I'd like you to also welcome Dr. Stacey Davis to the lectern. Dr. Davis.
Good morning, everyone. Thank you, Mr. Pete, for that welcome and introduction. And it is indeed a privilege and a pleasure for me to welcome and introduce the keynote speaker for today's symposium, Dr. Iris Navarro-Milan. Dr. Navarro-Milan is a rheumatologist, health services researcher, and implementation scientist. She's an associate professor of medicine at Weill Cornell Medicine, Division of General Internal Medicine, and the Hospital for Special Surgery, Division of Rheumatology, New York City. She was born and raised in Puerto Rico and received her medical degree from Universidad Autónoma de Guadalajara in Mexico. Her research focuses on factors that influence clinical outcomes among patients with systemic rheumatic diseases, particularly rheumatoid arthritis, lupus, and osteoarthritis. She has led multiple qualitative studies on the perspectives of patients with rheumatoid arthritis and lupus about their risk for cardiovascular disease, as well as the views of primary care physicians and rheumatologists on screening and treatment of hyperlipidemia in rheumatoid arthritis patients. She has expertise working using administrative claims, such as the Centers of Medicare and Medicaid, the Co-Evitas RA Registry, and the Regards cohorts. Dr. Navarro-Milan's major contribution to medicine is implementation science by using peer coaches to implement evidence-based guidelines. A peer coach is a trained lay individual who themselves has RA, lupus, or osteoarthritis, and who has been trained to guide participants to change behaviors that can help to improve their disease and health outcomes. She has 3 active behavioral interventions using peer coaches that are also focused on reaching underrepresented minority groups and improving the outcomes of members of these populations. Her interventions using peer coaches focus on improving cardiovascular risk assessment in patients with rheumatoid arthritis and lupus, preparation and recovery from total knee replacement in patients with knee osteoarthritis, and a non-pharmacologic intervention for mental health in patients with rheumatoid arthritis. Dr. Navarro-Milan is committed to mentoring and is expanding her work on cardiovascular disease and rheumatoid arthritis to patients with lupus through the junior faculty whom she mentors. She is the founding director of the Diversity Leadership Fellowship at the Division of General Internal Medicine at Weill Cornell. This fellowship focuses on developing leadership skills in junior faculty from underrepresented minority groups with the goal of diversifying the representation of minority groups in leadership positions in academia. Part of our work addressing issues with health disparities is the diversification of the healthcare workforce and increased recruitment of minority groups in clinical trials for rheumatic diseases. She will be speaking with us today on cardiovascular disease and lupus, understanding the connection and tools for predicting the risk. Welcome, Dr. Navarro, over to you.
Good morning, everyone. At the heart of the matter, such an important question and such an important concept, not only for lupus, but for all rheumatic diseases as well. Can everyone?
Yes, we're hearing you. You just need to share your screen and continue.
Okay, excellent. Well, when I saw everyone wearing purple during the introductions, I thought about going ahead and changing and coming in purple, but I did not have time. Thank you so much for the introduction. I am delighted to be here at the Lupus Foundation of Jamaica and discuss today this very important issue as a matter in the matter of heart. Okay, I'm gonna go ahead and share my screen. I just want to make sure that people can see it. Yes, I can see it. So let's dive into what is the problem with cardiovascular disease in people living with lupus, and understanding also how the prediction models for cardiovascular disease work and maybe do not work that well in predicting cardiovascular risk in people living with lupus. I have nothing to disclose, but here's my funding for my clinical trials. Today's objectives and what I will try to accomplish today with you is that you gain to provide you with an overview of cardiovascular disease in lupus. And then we're going to move quickly to the prediction models of cardiovascular disease in lupus, how well they perform in predicting the risk of cardiovascular disease. And at the same time, I'm going to be interjecting what are the overview of the treatment guidelines for prevention of cardiovascular disease. At the last part of the talk, I'm going to give you a brief overview of some of the tools that we're using to engage people living with lupus to have the right conversation with doctors about their risk for cardiovascular disease. So how is the risk for cardiovascular disease in people with lupus? In these three graphs, at the top you see myocardial infarction. The dotted line is the general population. The solid red line are people with lupus. You can see that the risk is way higher in individuals living with lupus for all outcomes compared to the general population, for myocardial infarction, for stroke, and the composite outcome, which is a combination of myocardial infarction and stroke. This is from a meta-analysis of multiple studies that consistently show across different populations that this is indeed a matter of fact, that people with lupus have a higher risk of cardiovascular disease. Now, but then the question is by how much, right? So it has been estimated that it's around greater than twofold the risk of cardiovascular disease for all three outcomes: myocardial infarction, stroke, and the composite of cardiovascular disease, which includes also peripheral artery disease, heart failure, and other cardiovascular diseases. And that overall elevated risk was sixfold higher than the general population during the first year of diagnosis with SLE. And this is where it is important, because most prediction models will use age of older than 40 years old. But most patients with lupus get diagnosed in their early 20s, maybe in their teens, and sometimes even children, right? So what are we, doing in terms of predicting this risk when the risk is so high at the first 6 months, but we haven't been able to determine an accurate tool because most of the tools are limited to individuals older than 40 years of age, right? So that is one problem that I'm already introducing of the reality of these prediction models and their shortcomings. And this risk stays around this high even after 5 years of their diagnosis, still way younger than 40 years of age, which is where the prediction model starts predicting cardiovascular disease. This increased risk was independent from traditional cardiovascular risk factors such as diabetes, hyperlipidemia, and hypertension. So lupus erythematosus induces an independent risk for these cardiovascular events. Now let me show you then the relative risk of for stroke in people with lupus in the general population, a little bit about how much. And this is overall, several studies were included in this meta-analysis, and you can see that the range is around 2.51 to 2.53 folds from the risk higher than the general population. That means that if there are 100 people with without lupus, and 4 people without lupus out of 100 get an event of cardiovascular disease, this is almost around, then it would be around 5.5, close to 6 people with lupus out of 100 people with lupus that will have then a stroke, right? So that is what these numbers mean. That was just a hypothetical example, just to understand that this is a relative risk. And the example that I provide you, the numbers that I provided you with the example with a 100 denominator was to illustrate the absolute risk. Let's talk then about myocardial infarction. And for myocardial infarction is always going to be higher because the prevalence and the incidence of stroke has decreased in the general population overall. So, but for myocardial infarction, it has decreased, but not as much as for stroke. And you can see that it can be up to 4 times higher that of the general population. And going back to that same example, let's pick a number of 3 out of 100 people without lupus will have a myocardial infarction. Well, if we take 100 people with lupus, then it will be 9 people out of 100. That's what this number will be. Actually, will be 12 because this is really a 4. 3.99 is a 4. So that tells you then the quantification about is elevated, then by how much is elevated, right? So knowing that, what we know, and I'm going to take another piece of information from these slides I'm going to incorporate later. And one of these is that some people have been using some multipliers of the general population prediction models to determine then more accurately the risk for cardiovascular disease. And some of these multipliers numbers come from this meta-analysis risk factor stratification. I'm gonna, not risk factor stratification, but the quantification of the excess of cardiovascular disease. And I'm gonna tap into that a little bit later with some articles that try to improve the performance of some of these prediction models for people with lupus. Okay, so that takes me to the second objective of our conversation, which is, excuse me, CVD prediction models and how well do they perform predicting risk in people with lupus. Note also that risk prediction is only done for primary prevention, meaning people that have never had an MI, myocardial infarction, a stroke, or heart failure. Because once a person had one of these events or had established diagnosis of cardiovascular disease, they need to go on full steam, doubling down on cardiovascular risk reduction approach. The risk is pretty much extraordinarily high, and that secondary prevention is very different from primary prevention. So the rest of the talk is going to be focusing on those individuals that were diagnosed with lupus and that have not had any cardiovascular event. How do we anticipate so they never develop it, right? Okay, perfect. And what I'm showing you here is the most recently updated prediction model from the American College of Cardiology and American Heart Association for different, for primary prevention in the general population. And you can see that the factors includes gender, age, race, cholesterol levels. Are you getting treated with statin already? If you're already getting treated with statin, then you don't need this prediction model, because this prediction model was really developed for people that were not on statin. So that will, disqualify you from the study, from the prediction once you choose that option. Systolic blood pressure, treatment for hypertension, history of diabetes, current smoking, and aspirin therapy. But you can see again the shortcoming is also for 40 to 79 years of age. And I already show you how these individuals that were diagnosed with lupus have a major risk during the first 6 months up to 5 years after their diagnosis of lupus, and most of them are not 40 years of age when they get diagnosed with lupus, right? So these already tell you a little bit of a shortcoming of this prediction model. So these can be only used in individuals older than 40. That's what we have, right? So let me show you then some other things that are important about this prediction model for individuals with lupus between 40 to 75 years of age. And is that while the American College of Cardiology and American Heart Association have not considered these factors in this slide to be included in the equation, they consider also a risk enhancer having a rheumatic disease such as rheumatoid arthritis, psoriasis, and also lupus, but it's not necessarily part of the prediction model. So then let's say we have every individual with lupus between 40 to 75 years of age. What is the cut point to start treatment, right? So let me reemphasize also what I just said earlier, that is a quantitative estimation and is at the population level, not at the individual level. So for clinicians, what is important to take into consideration is that this prediction model is at the population level, but then I have to tailor and take into interpretation the clinical factors, the demographic factors of the patient that I have in front of me. So then I can sort of tailor or personalize this risk to the patient with lupus that I'm caring for at the moment. So it is intended, this prediction model is intended for use if there is no atherosclerotic cardiovascular disease, meaning for primary prevention, and if the low density lipoprotein cholesterol is less than 190 milligrams per deciliter. Here are the parameters again that I showed you in the previous slide of the calculator of the tool, and also a reference of where you can get that tool and use it into clinical practice. But let's talk then a little bit about race, because one of the variables included is, you can see, is race, right? So when we look into the pool cohort equations, the majority of the people in these cohorts that were pooled to develop these equations were white. So what that happens is that while they include African Americans, there is an inadequate data for many racial groups older than Caucasians. So the overall recommendation from the American College of Cardiology and the American Heart Association is to take into consideration, which is the last bullet, that cardiovascular disease can be overestimated by this predictor model in Caucasians or whites, and can be underestimated in underrepresented minority groups in the United States, such as Hispanic, still is undercalculated or underestimate, yes, the risk for cardiovascular disease still in African Americans, Asians, and also American Indians populations. So that is a limitation about this problem with the pool cohort risk equation. But then we're going back to lupus patients. We know that most people with lupus get diagnosed between the 20 to 59 years of age. And the pool cohort risk equation has two calculations. One of them is a 10-year risk, and the other one is a lifetime risk. So while that, I show you already that the 10-year risk can be only calculated between 40 to 75 years of age, even within for individuals between 20 to 55 years of age, then the predictor model or the prediction score to take into consideration is the lifetime risk. And the lifetime risk includes a 30 years assessment of the risk for cardiovascular disease, and is a little bit more accurate, again, for the general population in individuals that are 20 to 59 years of age. So taking that into consideration, then the lifetime risk is probably a little bit more, better to use in individuals with lupus because they tend to be younger. Now, just a mathematical issue with the prediction model is that the 10-year risk may be higher than the lifetime risk. So if that is the case, the 10-year risk can still take preference over the 30 years risk because of the immediacy as well. That, if we can predict and control this disease within the next 10 years, we should be as aggressive as possible with our mitigation strategies. Still going around the American College of Cardiology and American Heart Association recommendation, going then into the United States Preventive Task Force recommendation, is that what they're trying to reconcile is that the prediction model is at the population level, but then how about the individual level? Can I use then other parameters to individualize my preventive cardiovascular risk reduction approach? And the parameters such as ankle brachial index, which is a marker for peripheral vascular disease, high sensitivity, a CRP level, or carotid artery calcification score, have not have enough evidence to be used or recommended to incorporate it on a regular basis as part of determining the individual risk of a person having a cardiovascular event. So they are discouraging because of the risk of harms. Remember, the carotid artery calcification score is based on computerized tomography, which has very, very high levels of radiation. And again, high sensitivity CRP can be also elevated in conditions not related to cardiovascular disease, such as lupus. Now, could this be, are these not mutually exclusive? Correct, they're not mutually exclusive. The high inflammation in individuals with lupus is part of the process of accelerated atherosclerosis in all rheumatic diseases, and particularly in lupus. So to tailor your prediction model is not necessarily recommended, but again, there is a clinical and individual judgment that the physician and the patient need to take into consideration once they are discussing initiating strategies to mitigate cardiovascular risk. Now, we talk about the predictions. So I got my prediction score on my patients. What do I do next, right? So for individuals 40 to 75 years of age, the prediction model said that, well, you need to have a clinical and patient risk discussion before starting a statin. And the risk mitigation is initiating a statin. Statins reduce 20% of the 10-year risk for cardiovascular disease for primary prevention, and up to 30 to 35% for secondary prevention, meaning that if a person already had a cardiovascular event or a stroke, initiating a statin has a major improvement in their risk, okay? Now, going back to absolute risk, if a 10-year risk of a person is 10% and statins decrease the risk by 20%, that means that the absolute risk reduction is still 2. So that risk goes from 10 to 8, okay? So these are tricky numbers, things to deal with, and that is why I'm giving you these examples of 10-year risk and how does that translate into absolute risk. And those are the numbers that I tend to discuss with my patients so that they can feel also very well informed about what happens if they go without treatment and what happens if they go with it. So they know what they're saying yes to and they know what are they saying no to. So what is the cut point to initiate for the recommendations to initiate a statin? Is 7.5% or greater. So in the 10-year risk prediction, if a person has a 7.5% increased risk for 10-year score for cardiovascular disease. The recommendation by these guidelines is to initiate a statin after discussing again, having a shared decision making with the patient and between the patient and the doctor, and if there are also some risk enhancing factors such as lupus and rheumatoid arthritis, they favor also initiating statins. Then if risk status is uncertain, you could consider then a calcium artery, coronary artery calcium deposition to improve the specificity. I have never used that. I still use the clinical assessment and knowing the risk factors of this individual that I have in front of me, just because this doesn't come without complications such as high levels of radiation. And the risk of the side effects of statins are relatively low. So the goal ultimately to know that the statins are doing their job in preventing cardiovascular disease is to attain a reduction in at least 30% of their LDL level, and if the 10-year risk, is greater than 20, reduction of LDL levels by greater than 50% are desirable. But still, a target of LDL level is not necessarily the goal. So in the adult treatment panel 3, which were the guidelines that were active up to 2012 approximately, and they say, well, you have to have if you have diabetes, your LDL needs to be less than 100 no matter what, right? So at least now if you're on a statin, you're already reducing that risk. It is still desirable if those levels come down even further, but having an established goal that we need to aim for 100 is not necessarily the case, but a proportion of at least 30 to 50% of what that individual had at the moment that the risk was calculated. So in summary about the guidelines for for the American Heart Association and American College of Cardiology and American Heart Association, is that the percent reduction in LDL can be used as a indication of response and adherence to treatment, but it's not necessarily a treatment goal. The pooled cohort risk equation estimates 10 years in individuals with and without diabetes, but then and then the cut point should be greater or equal actually than 7.5 in 10-year risk as an indication for initiating a statin. We have to also know that it underestimates the risk of cardiovascular disease in underrepresented minorities, overestimate the risk in Caucasians, and is also a population level prediction model. Now, what about the Q-risk 2? I'm not sure if you can see the top of my slide very well. The Q-risk 2 was developed in Europe and includes a bunch of other parameters, includes also rheumatoid arthritis and systemic lupus erythematosus. And you will say, yes, finally, we got the score, the prediction model that we need. But actually what's happening sometimes in the background is not that much better from what I showed you earlier, because I actually play a little bit with these tools as I was preparing this talk, and some of these the Q-risk the Q-risk 3 score, once I mark lupus, it gave me a lower risk than the American College of Cardiology AHA prediction model that I just talked about. So what some of these prediction models do is that they account or multiply the score based on those relative risks that I mentioned to you at the introduction of the talk to estimate then what is the risk. What they don't do is that they do not include disease activity itself. They do not include SLEDAI score or level of proteinuria or level of if you have actually lupus and lupus nephritis, which I already showed you that it has a staggering effect, and you will hear later from other speakers today that is the case, that having lupus nephritis is actually worse for the cardiovascular health of individuals living with lupus. So that is the shortcoming of the Q-risk 3, even though it still includes systemic lupus erythematosus in it. That still does not account fully for the disease activity of a person, which is dynamic and not fixed at one point, right? So what do we know then so far? So there are no prediction model for primary prevention validated for people living with lupus. Multipliers appears to be reasonable, which is what I showed you in the previous slide, but it has several shortcomings. And this is what these investigators from Canada did, using, again, a predominantly white population, where they took the Framingham risk score in the top row here, and they calculated a risk for people with lupus, and they say, oh, look at this, the risk is 2.9%, the 10-year risk is 2.9% with a specificity of 98%. Oh, that's very high specificity, that looks very good. But is this risk too low for individuals? Yes, likely. So they went ahead and multiplied by 1.5, which is the risk of diabetes compared to the general population. Also the risk for cardiovascular disease in people with RA, rheumatoid arthritis, compared to the general population. And then the risk increased a little bit more. It reached the 7.5 cut point, a 10-year risk. But then the specificity went down. And they estimated, they concluded that multiplying the Framingham risk score by 2 was predicted better cardiovascular disease in individuals with lupus, even though the specificity decreased. And then the 10-year risk went all the way up to 20% from a 2.9 without multiplying. But this has several shortcomings, and is that they did not recalibrate the contribution of each component of the Framingham risk score for people with SLE, meaning having hypertension and SLE might have a different weight and a different contribution than in the general population. And that is something that has to be done when we are recalibrating these general population risk prediction models for individuals with lupus. And then they did not evaluate the effect of each factors on various outcomes. So they needed to account for each of these Framingham risk prediction scores, which took many, many years to do, since the 50s and 60s that the Framingham score, that the Framingham cohort was founded to determine then, hypertension has a major effect on diabetes. We know that diabetes is one of the major contributions with a, increased risk of 50%. That's where the 1.5 increased risk from diabetes comes from. So those aspects have to occur in individuals with lupus. And there are several reasons for why we don't have a validated model for people with lupus, is that we need as many years as Framingham has to determine then 10 and 30 years. We need 10 and 30 years follow-up. This study only had 9 years of follow-up. So you can predict the model up to 10 years, but then the long-term year that is recommended for people younger than 40 cannot be answered with the data that we have at hand. So that is one of the issues, another of the many issues for which we don't have a good prediction model for people with lupus. But then I'm sorry to disappoint you now, and is that all these prediction models, and I told you about the general population, can unfortunately go very quickly out of the window. But with that, I want to give you hope, because I hope that after this slide, I can get the team of the Lupus Foundation from Jamaica to get their efforts together to then develop something that really helps the Jamaica population of patients living with lupus to better predict the risk for their people. Why? Because these prediction models that we have are made from Europe, are made from the United States and Canada, and really doesn't represent very well the Caribbean population of Jamaica and Puerto Rico. So with that in mind, these investigators, this group, I think was from Harvard, published this viewpoint, a very interesting one. I gave you the reference there, that is about the myth of generalizability in clinical research and machine learning in healthcare. While machine learning is a new concept, prediction models really, in what machine learnings do is that they try to predict the future and identify which are the variables that best predict the future, how best you predict response to cancer treatment, how best how likely is that you're gonna come off of the ventilator if you develop COVID-19 and become intubated, right? So, but the shortcoming about the generalizability is that there is an emphasis that one size fits all, that because it works in the United States or in Canada or in Europe, it means that it will work the same way in Latin America. And that is not necessarily the case. So I think, and this is where my efforts in my research program has been, is that I'm going to focus on the population that I serve in my clinic so that I can identify prediction models with the variables and of the people that I serve from my community so that I can re-stratify those individuals much better than using a population-based prediction model that is for the general population that exclude the people from my community, right? So that we should probably do a more narrow focus, small effort to collect this data and then build more robust prediction models for the people that we serve. And that is where the inspiration probably I hope to cause in the audience is to say, well, maybe we should build in this registry, or if you already build it, then look at the data of those registry in Jamaica of people living with lupus to then establish a prediction model for cardiovascular disease in people with lupus of the community that you serve. Why? Because there are changes in practices and patterns over time that are not accounted in some of these prediction models. There are differences in patients' demographic, in also social determinants of health. As you notice, none of these prediction models also include social determinants of health, which explains around 80% of the health of all of us, right? So what are those factors that affect our community? So the food for thought is, let's get together here in Jamaica. Let's put our registry together. Let's see how our community looks and how hypertension, how lupus, and how diabetes really affect that cardiovascular disease in our patients, and then build something that helps small but big time your community. Very, very wonderful viewpoint. Okay, so a few more slides. Lastly, well, Dr. Navarro, you're telling me that there is nothing that can predict very well primary prevention for cardiovascular disease in people living with lupus. What do I do? So what the European and also the European Organization for Rheumatology, also known as EULAR, and also the American Heart Association and American College of Cardiology still recommend that the estimation of cardiovascular risk in patients with rheumatic diseases, such as people living with lupus, should follow those of the general population. So the prediction model that we should use is still the one that I show you, either the pool risk equation or the Q risk 3. There is also the SCORE treatment, the SCORE prediction model. In America, we use the pool cohort risk equation, and you will see that in European countries, they tend to use mostly the SCORE because they were developed with their countries, right? So that is why, we need to do something in the Caribbean. Maybe Puerto Rico also should partner with Jamaica and Dominican Republic to get something together that is, can be have a benefits across the Caribbean populations. So CVD risk assessment is also recommended within the first 6 months of diagnosis and repeated based off individual risk factors. You see now, acknowledging, EULAR is already acknowledging the shortcomings that these prediction models are population-based. CVD risk factor management and goals should follow recommendations and strategy for the general population, the use of beta blockers, the use of statins, and so forth. But then they also comment about other lupus-specific CVD risk reduction strategies that I'm not going to touch into detail, but others today will, is about keeping lupus disease activity low, limit as much as possible, which is a major challenge, on the use of glucocorticoids. But unfortunately, to date, the EULAR does not recommend that the use of immunosuppressive medications to lower cardiovascular risk. It seems that hydroxychloroquine is the one that probably has the strongest data for cardiovascular risk reduction compared to other immunosuppressants from lupus. Now, Life Essential 8. I'm not sure if you're familiar with this. This is an effort from the American Heart Association in reducing lifestyle modifications to lower cardiovascular disease in the general population. So what is that about? It used to be Life Essential 8. It consisted of healthy diet, exercise, glucose control, weight control, well control of lipids, hypertension, smoking cessation. So they added sleep. And this is a major problem in people with rheumatic diseases, because across all of the diseases that I treat in my practice, the vast majority of my patients, unfortunately, do not sleep. And these have limitations in sleep can have impact on their disease activity, their cardiovascular health, and the risk of cancer. So that is why they're putting a major effort on Life Essentials 8 in improving also the quality of sleep. Now, let me share with you the last part of the effort that we're doing. And this is my mentee, Dr. Megan Chrisman, who is now at the University of California in San Francisco, where we together developed the cardiovascular risk assessment for patients living with lupus. And what is that? So this is an educational program for people living with lupus that helps them have a conversation with their rheumatologist about the importance of getting their cardiovascular risk assessment. The good thing about this project is that it's not about getting a cholesterol test done. It's not about getting a statin started. It's about having the right conversation with their rheumatologist, and not only at one point, but in a longitudinal way, where this is something that is visited and discussed at every visit, or almost every visit, with their rheumatologist. And several things that we found in our assessment to develop the care for lupus program was that many people did not understand very well what was lupus. So there was an issue with health literacy, how lupus was treated. I know I am on belimumab, but what does it do? What does it really do for me? And then why is my risk for heart attacks and stroke higher because I have lupus? I want to know why, and I want to know how to lower it. So then we developed these 3 sessions of several questions and answers sets that are posted in the pulseforhealth.com website, where you can where they see the question and then they can see the answers of it. And with that, I want to show you briefly the Pulse website. I don't know if you can see it here. This is pulseforhealth.com. And if I type the word lupus, then you can see how does lupus affect my heart. You can click on it. And then it has several information. It should have a picture here about what is the process. Then it also shows the patients that it was created by doctors, that is not created by pharmaceuticals or bloggers or anything like that. It has an endorsement of an academic center, which increases the trust in the content. And that is why we take this very seriously. And then it has See the Science. The See the Science is a scientific language summary of the evidence with the citations. One thing that we heard from patients is that they wanted to know that this was indeed real and that it was not put 2 and 2 together, that it was curated and it was peer reviewed and so forth. Plus, we have patients that thought that this content was very simple, very easy to follow, very good for them, and they absolutely love it. Love it. But then some others said, well, that's too simple. Can I get a little bit more sophisticated information? So we don't need to create something different. We just ask them to tap on the See the Science. And here are also some infographics about how to tell people with lupus to lower the risk. We're in the process of developing some cartoon videos to make the content a little bit more engaging for people with lupus. Okay, so can you see my slides again or not yet? I don't think that you can. Okay, now you can. All right, perfect. So that's an ongoing project. We're still recruiting patients, and what we are looking into that is to see how many people get their cardiovascular risk assessment done if they're living with lupus after they complete the program, before and after, and also the knowledge that they get about the risk of cardiovascular disease, because we found that many patients in our center are not aware of this increased risk despite having lupus even for 10 years. So doctors are not discussing this risk with their patients. So this has then the patient engaged and the doctors accountable. And we have found that that combination has really worked very well for rheumatoid arthritis. We'll see if it has the same effect in lupus. Okay, so what are the main take-home messages that I want for you to take? I'm preaching to the choir. Cardiovascular disease risk is higher, way higher in individuals living with lupus compared to the general population. Unfortunately, there are no specific risk prediction model for patients for lupus, but there is still light at the end of the tunnel and is to develop intentionally and prospectively something and prediction models that can serve patients with lupus within your country, within your own community. Prediction models are only also for primary prevention, secondary prevention, or for people that already had a heart attack or a stroke. They need to be on full-blown mitigation, risk mitigation treatment. These prediction models predict at the population level, not at the individual level. That individual assessment needs to be between the physician and the patient. So this is very important. The CVD risk estimate is at 1 point, and I want to encourage that is another major shortcoming about risk prediction on any disease, more so in lupus. And it's because people have high blood pressure that goes all out of control, or diabetes, A1Cs that goes into 8 and then go back to 7. So the same happened with also disease activity from lupus. How are those fluctuations in disease activity really has changed the risk over time? That is a major shortcoming about these risk prediction models. So that is why the clinical encounter is still very important. If I have a person that I have not been able to get into remission, but have been fluctuating mostly into low and moderate disease activity, maybe even high disease activity, that is a person that I will probably have to be more cognizant about initiating a statin as primary prevention for cardiovascular disease. Let's not forget the holistic approach. Take the approach of people living with their social demographics, their sleep habits, and also the incorporation of the life essential 8 factors into your approach and management for people with lupus to mitigate that cardiovascular risk. So I mentioned this already, and this is, I think, the most exciting part, and is to focus on developing prediction models for the people that we serve, that we care for, that we see all the time at bedside. And that, these risk prediction models do not include social determinants of health, which there is an effort in Europe to do that, not so much in the United States. So I'm not very familiar to see what is the effort of including social determinants of health in prediction models in Latin America and the Caribbean. But if that is an effort that the Lupus Foundation of Jamaica is planning on take on, I would really, really encourage to incorporate that as well as part of the efforts of developing a prediction model for your own communities. Thank you so much for your time. And here's my email address so that if you're interested in using Pulse in your practice, if you're interested in collaborating and maybe creating some form of a consortium or coalition from the Caribbean, I would be very fascinated by partnering with you to make this a reality. Thank you so much for your time.
Dr. Navarro Milan, that was extremely useful. On behalf of all of us here in Jamaica, we want to thank you for taking the time from your busy schedule to share your expertise with us. You have certainly highlighted some important factors when caring for our patients with lupus and cardiovascular disease. And I think one of the important take-home points is looking at your population and looking at the population in terms of the peculiarities of lupus with cardiovascular disease. Thank you.
You're very welcome.
All right. We are going to move on to the question and answer session for this segment. I think I'll start with a question that I have. And I certainly agree that risk stratification and primary prevention should be our focus. We don't want our patients to have these events at all. But in the context of Jamaica, where we see quite a few patients presenting, I'm curious to know if we believe that the traditional secondary preventative measures would be adequate for our lupus patients. And I'm going to give some context to my question. In the month of October, the consult inpatient service at the University Hospital, the first week of the month, I got a call about a patient, an 18-year-old patient who is a physically active young lady, no underlying chronic illnesses, who presented with a right hemiplegia. Now, interestingly, I had seen this young lady, and a hemiplegia is a loss of total function, 0 out of 5 power on one side, because I know we have a mixed audience. So I had seen this young lady 1 week before in my office. She had been referred by her general practitioner, who had been following her for almost a year because she had some joint pains. These pains were extremely nonspecific. Frankly, as a rheumatologist, I was quite underwhelmed by the history and the physical exam and thought that maybe this was just some undifferentiated inflammatory arthritis that was evolving. Interestingly, though, imaging confirmed that she had a middle cerebral artery block, a thrombus. And had it not been that she was from a socioeconomic bracket that she could afford fibrinolytic agents, we're looking at an 18-year-old's life, her whole adult life, the trajectory of it would have been changed. And when we think of the average socioeconomic patient that we deal with, it's very concerning. Another case, 2 days ago, Friday gone, is a 35-year-old male who has had a long-standing history of lupus. He has been non-compliant on and off. He also has kidney involvement, but he presents after developing chest pain and basically comes in with 100% blockage to his RCA, to one of his major coronary arteries. And so we're seeing these patients basically go from 0 to 100 in front of us. They're not having minor events. They're not starting with a little TIA or some angina. These autoimmune lupus patients, because interestingly, the young lady, her labs had come back while she was in hospital, and she had high titer double-stranded DNA, high titer Smith, and high titer RNP. So we realized that this stroke was indeed related to lupus, in spite of the fact that she really had such vague musculoskeletal complaints. Do we think that if the pathway to coronary artery disease is different because of the involvement of the autoimmune illness, are we convinced that the standard secondary prevention is going to cover these patients? Is there anybody doing any work looking at this?
I don't think that there is any data to support that. I don't think that, I'm not aware of any work doing that. So I want to make that distinction. I don't think that there is any data. But what data? We have very limited data in rheumatology in general. So sometimes you have to make a decision about, listen, I have this patient in front of me, and would I be penalized for not practicing evidence-based medicine if I am going to be preventing a disease that is highly preventable? Probably not. And what I do, and I would take my approach to those situations, is that power to the patient. I disclose the risk, the risk benefits of these strategies for secondary prevention that I think will be a good fit for them. And if they say, and let them decide understand what are they saying yes to, what are they saying no to, and then I make that conversation clear. Now, based on data, no. Based on clinical and practical practice, have I done it? Absolutely. In these particular cases, it's a little bit more challenging because some of them were not even diagnosed yet, right? So that is why probably the risk of cardiovascular disease is so high within the first 6 months of diagnosis, because there is a preclinical accelerated atherosclerosis. We have seen that in RA, but that has not necessarily that well studied. When you see the meta-analysis, most studies include people with RA and psoriatic arthritis, and very few of people with lupus. So that makes sense why so quickly after the diagnosis they got this problem, because they were having it before that. So I would say just follow your patient, follow the recommendation, what the patient is telling you, what is presenting, and do the best to help this from happening. So I tend to be quite aggressive in the use of statins. So if a person is not in well control and he has at least 10 years of lupus, or is having 10 years of lupus, the risk might say, oh, you have a risk of 3%, you're going to be on a statin if you are my patient, because this is, especially if also you're a minority group, because social determinants of health play a major role in these individuals. And I take ownership on that as a rheumatologist. I don't wait necessarily for a primary care to take those approaches. So we're going a little bit outside of evidence-based practices, but I think that's allowable. I really think so.
Yes. And then as you speak of statins, we've had this age-old debate about whether our lupus patients should be on statins, regardless of risk, just because of the higher risk of cardiovascular disease. Our guidelines don't encourage that.
Correct.
But I have seen where there is data talking about if patients have APLS antibodies or persistently elevated high sensitivity CRP, whether or not that cohort or that set of our patients should be put on a statin. Do you have any personal comments or opinions on that?
Yeah, so my opinion is that not because you have lupus, you have to be on a statin. But if you have if I have in front of me a person that is having moderate to high disease activity, and if you have lupus and you have lupus nephritis, I would at least put you on low intensity statin, because lupus nephritis has a staggering effect. I think there is a speaker talking about lupus nephritis and cardiovascular disease later today. So that tends to be the approach that I take, but not everybody's the same. It's not one size fits all, but I tend to be a little bit more liberal on prescribing that, but not too liberal to say everybody needs to be on a statin either.
Okay. I think we're going to go ahead and take questions from the audience now. Start with Professor Toller-Reed.
Thanks very much. Thanks for that lecture. It was very interesting. There are a couple of things that I kind of want to ask about in terms of cardiovascular risk, and whether or not a lot of the events that you may see in patients with lupus or rheumatological diseases are the typical events that would take place in a person who has normal atherosclerotic disease, because I know there may be a higher risk of thrombotic disease and so on. So the stroke and MI, in terms of the pathophysiology, would you call them all the same as for the general public? That was really one question. And then the second question I had was really all about cardiovascular risk prevention. And you mentioned two things which were critical. One was the fact that you're looking at a very young population. And for me as an endocrinologist, thinking about cardiovascular risk prevention, especially for younger patients with diabetes, you're always wondering what's the best thing to do if this person wants to get pregnant or have children. How can I reduce their risk without putting them at high risk for complications should they choose to have a family or make decisions like that? So my two questions were about the pathophysiology of cardiovascular events in lupus patients, whether it would be similar to the general public. And then the second one was about other methods for cardiovascular risk prevention. You mentioned a couple with the choice of drugs and avoiding certain therapies, but the things that we typically know reduce risk, like statins and ACE inhibitors, may not be the best for a woman in reproductive age group. So I just like feedback on that.
Yes. So what we learned from the Women Health Initiative, for example, is that cardiovascular disease, even in women, is different from men, right? Women tend to have the small vessel, diffuse, tiny small vessel cardiovascular pathology, and men tend to have the more, major coronary vessels occlusion. So I don't think that pattern that occurs between men and women has been described to be particularly different in rheumatic diseases, except that it's extraordinarily fast. And we see individuals experiencing this kind of very advanced atherosclerosis at very young age, or just within a year or two of being diagnosed with a rheumatic disease. We speak about the little bit of the subclinical part. That is my knowledge about that. There might be studies out there that are really trying to understand if the pathophysiology of the coronary artery disease and atherosclerosis occurs in lupus. Yeah, I think there is some body of work on rheumatoid arthritis and psoriatic arthritis, and they have shown that it's not much different from the general population, except that it's faster. New studies about that, I might not be up to date on that, so don't quote me on that. Regarding the question about childbearing age, that's a very important one. I recently had a young lady in her 20s have her first baby, and lupus nephritis as well. So yes, I mean, I think that the approach is the same that we do with immunosuppressants. So there are some immunosuppressants that people with lupus cannot take while they are planning a family. So we try to maximize to achieve the low disease activity as possible from lupus before we recommend. I recommend pregnancy, and then once they have reached the lowest disease activity possible, we have to stop immunosuppressants for several months sometimes before they can start getting pregnant. So now after pregnancy, during nursing, we start talking about, how long you're planning on nursing your baby. We need to get started back on your immunosuppressants, and we need to get you back on your cardiovascular risk reduction. So it is something that we need to pause. Fortunately, is for 9 months, is not forever, and every single pregnancy that they want to do has to be a very, very close discussion. And I take to, with all my childbearing age patients, not only for lupus but for all diseases, I say if you're planning to have a family, we need to have a discussion first and before you talk it with your partner, because this can have major impact on you and on your baby. Remember, some of our immunosuppressants can cause problems to the fetus and and also frequent abortions and miscarriages. So that is why we need to keep that balance. So keeping that immunosuppressive approach is the same approach that I tend to follow, the same for cardiovascular disease, such as ACE inhibitors and statins. I tend not to use ACE inhibitors in young individuals unless they have major issues with proteinuria. And but statins, I'm a little bit more liberal on that.
Okay, and we're going to move to some questions from persons with us online. And the first question is, any update on how soon tofacitinib is likely to be approved for SLE, given the potential cardiovascular risk reduction benefit for patients with lupus?
I do not have an update on how soon tofacitinib will be likely to be approved for patients with lupus. And as EULAR recommended, immunosuppressants should not be used as a way of reducing cardiovascular risk. We know about the oral pharmacovigilance efforts about how JAK inhibitors have an increased risk of cardiovascular events, serious infections, cancer in individuals with rheumatoid arthritis. So, JAK inhibitors are one of those drugs that I am more reluctant actually to use in my clinical practice because of their safety issues. And also the efficacy has been sort of a 50-50. So if I have better options for immunosuppression that are more consistent and more more predictive, I'd rather use that instead of dealing with a medication that can also potentially increase the risk. Now, in younger individuals, the risk for cardiovascular disease might be less concerning, but not if a person has lupus. As I already showed you, this risk is very high, even in people with lupus that are in their 20s.
Okay. And then the next question we have is there more incidence of lupus since COVID? And is there any increased incidence of cardiovascular disease, especially thrombus, in these patients since the COVID pandemic?
So the data on that is mixed. And again, full disclosure, I'm not totally up to date on this. There was an article just, I think, was published in JAMA, not maybe like really literally 2 weeks ago, that said that yes, there is an increase of incidence of rheumatic diseases all across, or autoimmunity since COVID. But then some studies from the United States have not shown that there has been much difference in terms of incidence of rheumatic diseases or lupus. So it depends on the population, and maybe this came from China because China was 6 months, 2-3 months in the pandemic before us. And here in New York City at one point was the epicenter of the pandemic. So there are multiple registries following these patients longitudinally, and we are enrolling patients into this registry, even across institutions. Even if I don't have a registry for that at my institution, I send them to another academic organization here in New York City to try to figure out this question. And it has been a very, very rare incident. I think I've seen a couple of patients that developed some autoimmunity with Sjogren's syndrome, but it was probably 2 since the pandemic, not enough to make conclusions. So it will be interesting to see, to dig deeper into that article from China published in JAMA to see what was the temporality and how they actually conclude that this was attributable sorry, to COVID, right? That is the challenge there. Now, the second part of the question tends to be a little bit less relevant because the first question we don't have a clear answer. So once we have a very clear answer on that, we can then answer the second one.
Okay, well, it's actually reassuring that so far there doesn't seem to be a lot of incidents of lupus, and it sounds like we get our answer in the future as time goes.
From collaborators, not necessarily from me, but I collaborate a lot with people. I mean, I get my own studies, but then if I know of a person that has a study that this person might suit them, and say like, hey, you need to go to this other investigator. They're doing a phenomenal job about trying to find out this answer. They're best for you. So for the well-being of everyone, right? That we have enough information for everyone.
Definitely. Do we have any other questions from the audience? Yeah, I think I see one. Okay. Actually, we have
my email address in the
chat. So anybody who has any questions can contact you. Sounds good.
Yes. And building also some collaboration with rheumatologists from Puerto Rico. So that is, that was one of the reason that made me very excited to join this conference. So maybe we should do something across the Caribbean, especially with the PALS. The PALS to educate patients. We're trying to do this in Spanish, in English, and we want people in the Caribbean to use it. We have several investigators at New York that are from Jamaica. I care for a lot of patients from Jamaica, actually, here in New York City. And I would like to see, if you find a utility for it. So far, we're just asking for an attribution of the PALS that is from Weill Cornell, and that's it. You can use it, but we just want to know that you are indeed using it, finding it helpful, what is not working, and so forth.
Okay. And we have a comment from one of the founding members of the Caribbean Association of Rheumatology, who's from St. Lucia, who says, certainly, we would love to collaborate and have more information specific to our populations. So you should be hearing from us.
Okay, wonderful. And I think I typed my email only to that person. Let me see if can everyone see it now in the chat? I don't know.
I'm not seeing it, but if anything, we can give it to anyone who's interested. I think at this time, we would like to thank Dr. Navarro Milan.
Thank you.
For sharing with us. It has been a great session. I think we've all learned a lot. And we want to thank you for your great work for lupus and autoimmune patients in general. Thank you.
Thanks to you. Thank you for having me here. A true privilege.
I'd like to once again thank Dr. Stacey Davis and Dr. Navarro Milan on what I thought was a very thought-provoking presentation. Certainly a number of things resonated with me, as Dr. Stacey Davis mentioned, which of course speaks to the whole development of that database, which will help to share between Latin America and the Caribbean for the population that we serve. And I'd like to thank her for raising that conversation. And again, thank Dr. Davis for navigating through this section entirely. I would also like to remind you that you can send in your questions to the number 876-778-3892. But certainly, there are other options that are available to you. And of course, by looking at the back of the program, there is a QR code that is available that you can, well, the QR code is not for the questions. The QR code is for you to recognize that the Lupus Foundation of Jamaica is here to help not just lupus patients and their families, but to help all persons who are interested. And we invite you to donate and to be a part of the foundation and to help us to grow and to be stronger. At this time, I'd also like to acknowledge and thank the sponsors, the Partners Interventional Center of Jamaica. This is one of our platinum sponsors, and certainly without whom we would not have, been as successful as we have, as well as the other sponsors. I'd like to ask that we play that video from the Partners Interventional Center of Jamaica.
Hi, I am Dr. Victor Elliott. I'm an interventional cardiologist, and I have been practicing for over 16 years, which means I've had experience in doing thousands of angiograms, angioplasty, and stenting. And I have seen all sorts of complications and problems which can occur. I am one of the cardiologists and the director of Partners Heart and Health. And our goal is to provide the utmost care and the best cardiac care for our Jamaican citizens and anybody else who wants to fly in and to benefit from our resources. Partners Heart and Health is a cardiovascular center which has been using new and innovational technology in providing care for our patients' health. Some of this technology which we have introduced include cryoablation therapy for atrial fibrillation, ASD and PFO closures, transcutaneous aortic valve insertion, and the use of intravascular ultrasound, IVUS, for better imaging for our patients undergoing coronary angiography and stenting. So for this feature, we are going to focus on the benefits of intravascular ultrasound, IVUS, and its use in improving the care of the patient who undergo coronary angiography and stenting. So IVUS, as the name says, intravascular ultrasound, involves passing an ultrasound probe into the blood vessels to get a better image of the blood vessels. So while an angiogram will give you an image from outside in, the IVUS gives you an image from inside out. And as a result, we get a lot more detail about the blood vessel. We can actually see and measure the size. We can measure the size of any plaque, thickness, see how much stenosis there is, if there's calcium and the extent of calcification, and hence the better way to treat these vessels than what an angiogram would normally give us. IVUS is different from a plain angiogram is that an angiogram just involves injecting the dye or contrast into the vessel so you can get an outline of the vessel. It really does not tell you the actual size of the vessel. It does not tell you, is the vessel calcified? It does not tell you how tight the stenosis is. With intravascular ultrasound, we can answer those questions. So your doctor is no longer guessing, what size vessel is this? What size stent do I need? He can measure it and get an accurate account as to what needs to be done. And this is not just for the numbers. There are many studies which have shown there is improved outcome for the patients who undergo IVUS. There's decreased mortality. There is decreased redoing or to redo the procedure. There's decreased incidence of in-stent restenosis. And so the outcome for the patients are so much better. It is so much so that the American College of Cardiology, as well as the European Society of Cardiology, has indicated that IVUS should be used basically for almost all coronary angiogram procedures. Now, doing IVUS requires no further preparation for the patient than for when they go to do a coronary angiogram. As per se for coronary angiogram, we will ask the patient to not eat a couple of hours before, make sure they walk with their medication. They would have done blood studies prior, but they just come to get the procedure done. And as they will do the angiogram, if we do believe that IVUS is indicated, that is, if we believe there is a possibility of a stenosis in the vessel, then we will just, along with doing the angiogram, just pass the IVUS probe into the vessel to get the details that we know will make a difference in the outcome of the patient. When we're doing a typical angiogram, it involves injecting an iodine-based contrast, which for some patients can put a lot of, let's say, stress on the kidneys, and hence can worsen kidney function if you already have some form of kidney or renal impairment. For those patients, it is vital that we do what we call a low contrast study. And what is more low contrast than the intravascular ultrasound? You actually don't need contrast to do the intravascular ultrasound. So those patients with especially grade 4 and grade 5 renal impairment can undergo this assessment with very little contrast being used, and hence no threat to their kidneys or worsening of their renal function. As a matter of fact, in some centers, they can do a whole study, including putting in stents without using more than, say, 3 cc's of contrast. IVUS does make a difference, especially for these patients. And us at Partners Heart and Health, we have done studies similarly to this and have preserved patients' kidney function. I recommend IVUS because it makes a difference. It has made a difference for me as an interventional cardiologist in assessing the vessels that I'm working on. It has made a difference in that I can predict problems that could occur, and hence to have the right tools to make sure I can open up that blocked vessel. It makes a difference in that patients are coming less often to have another procedure done. And it makes a difference, most importantly, in reducing mortality, improving patients' lifespan. It's the goal of what we do. And so as an interventional cardiologist, I recommend that if you're like the ACC and like the ESC, if you're going to be doing a coronary angiogram and possibly angioplasty and stenting, IVUS should be a part of that procedure.
Interventional Center of Jamaica, one of our platinum sponsors. Certainly, we will be introducing the other sponsors as we go through the program today. But I'm very happy to say that I'm very delighted at how the conversation started. Truly has gotten to the heart of the matter. And yes, as you know, the theme, Lupus, you, me, stronger together. Now, I just want to make public endorsement of the participation of reigning Miss Jamaica Universe 2023, Dr. Jordine Levy. Herself a medical doctor, she's also an advocate for lupus awareness and very supportive of our campaign. I know we're running a bit behind time, so I'd like to sort of speed things up. And at this juncture, we'd like to move into the second session. This session, which will be speaking to the nuances of cardiovascular diseases in lupus. Our moderator is Dr. Asana Anderson. Dr. Anderson is a consultant rheumatologist at University Hospital of the West Indies, and she will introduce the segment and introduce the speakers that will be involved here. Dr. Anderson, would you kindly join us? Can we hear an applause for Dr. Anderson? Thank you.
Thank you. Thank you. Good morning, everyone present and to everyone online. Okay, so we're going to jump right into session 2, cardiovascular disease in lupus. I'd like to welcome our first speaker, Dr. Laurie Fisher, who will be speaking with us about lupus, the kidney, and cardiovascular risk. Now, Dr. Fisher is a consultant nephrologist at the University Hospital of the West Indies and an honorary lecturer in the Epidemiology Research Unit of the Caribbean Institute of Research. After completing residency and fellowship in the United States, she returned to Jamaica. She's currently the deputy chair of the North America and Caribbean Board of the International Society of Nephrologists and is a member of that council. Her research interests include the epidemiology of kidney disease and its risk factors in the Caribbean, as well as sickle cell nephropathy. She's published on acute kidney injury and chronic kidney disease in Jamaica. Dr. Fisher is passionate about patient care, and we are happy to have her. Dr. Fisher?
Good afternoon. Well, good morning, everybody. Thank you so much for having me to the organizers. And I'm really happy to talk on this topic. Yeah, cool. All right. So I wanted to start off with a case. So this is a 56-year-old lady, MJ, who I'm seeing for follow-up of her kidney disease. She has mild kidney disease, stage 3A. She's had lupus for 20 years. And I know the rheumatologists will be proud of me because I put their how the diagnosis was made. So her ANA was positive. She had immune cytopenias, nephritis, and arthritis at the time. She had lupus nephritis 8 years ago. It was class 3 and 5. She was treated with MMF, which is mycophenolate mofetil, and steroids, and had a complete response essentially at 2 years. She was treated for a total of 3 years, but she now has baseline CKD, and she presented to me for kind of follow-up of her CKD. In terms of her history, she's hypertensive for about 8 years. She's a never smoker, no history of diabetes. Her lupus has been quiescent for the past year or so. She's had no flares, no clinical disease activity, and she's maintained on HCQS, perindopril and amlodipine, Cellcept 500 BD, and that was primarily for control of her lupus and as a steroid-sparing agent, and L-thyroxine. Her blood pressure in clinic was good, 118/76. Her heart rate was 78. She's a little obese. She's 30 kilograms per meter squared. Her labs looked okay. From a renal perspective, her creatinine was 120. For Americans in the group, it's 1.3. Her GFR, which is the function, was 49, which puts her at CKD stage 3A. But she has some proteinuria, so albumin creatinine ratio of 340 milligrams per gram. So that's severe albuminuria, and a UPCR of 0.8. Her A1C was done. It was 5. Her total cholesterol is 5.5. That's mildly elevated for the lab, and HDL was 1.7. So the question is, what is her cardiovascular risk? So as we all know, lupus is a chronic inflammatory disorder which can affect any organ, and it's marked by immune dysregulation, and it's prevalent in women of reproductive age. In terms of the kidney disease is really common, occurs up to 50 to 60% of our patients with people of African descent and also Latino descent, increased risk of poor outcomes, lack of response to therapy, and at worst, they're higher risk of progression to end-stage kidney disease. We know, because we're having a lecture today on cardiovascular disease, that cardiovascular disease is one of the leading causes of death. So we just wanted, I know that a lot of our presentations will overlap, but the focus of my presentation today would be to kind of describe a bit of the epidemiology of the cardiovascular risk associated with kidney disease in general, the overall risk specific to lupus nephritis, and a little bit of pathophys, what we know, and a lot of what we don't know about lupus nephritis and its interaction with cardiovascular disease. And again, a little bit of the assessment and management. And that the last part's a bit difficult because there's not a lot of kind of risk assessment tools for our lupus nephritis patients. So chronic kidney disease, just to kind of define terms, is based alterations in either kidney function or structure lasting 3 months or more. And that is manifested as either an estimated GFR, meaning that glomerular filtration rate or function of the kidney of less than 60, or markers of kidney damage. The marker of kidney damage that we tend to measure is albuminuria, so increased urinary albumin excretion, and that more than 30 milligrams per gram on spot testing. Everyone always gets confused by heat map in Kidogo, right? Because nephrologists just like to confuse everybody. It's our secret. So the heat map, so everyone thinks of kidney disease in terms of the risk to dialysis, right? But the truth is, most people with chronic kidney disease do not end up on dialysis. They die from cardiovascular disease. So what that heat map means, green, yellow, and red, well, green, yellow, orange, and red, sorry, orange and green together. But anyway, so green means low risk. So those people who have normal kidney function, no proteinuria or no albuminuria specifically, are low risk for cardiovascular disease. Red, which you'll notice is CKD stage 3A, A3, meaning that they have a function of between 45 and 59, but they have severe proteinuria, so albumin creatinine ratio more than 300. They're actually red. They're high risk of cardiovascular disease. And that's really important. So yes, we think about progression to end-stage renal disease ultimately as our outcome in end-stage in CKD. But CKD, to take home the point of the slide, is that CKD is a high risk for cardiovascular disease, right? So I really like the slide to the picture to the right. So if you look here, I don't have a pointer, but this is the annual mortality for end-stage renal disease. So that person who is 25 to 34, that person who has end-stage renal disease has a 500 to 1,000 times risk of death, predominantly cardiovascular death, compared to anyone in their age group, even at age 25 to 34. Right? They're actually, so the reason why there's an arrow across the line, their mortality actually approaches someone who is about 75 to 84. So think about that. The next slide is, or at least the next picture beside it, is that cardiovascular disease and mortality is independently associated with CKD, with the risk increasing with GFR and with dropping GFR and increasing albuminuria. And so people whose function, let's say, is between 15 and 29, putting them at stage 4 kidney disease, they're up to 10 to 20 more times likely to die from a cardiovascular complication. And that's kind of that graph there. So enough about the kidneys, but what about lupus and cardiovascular risk? I tried not to go too much into this because I'm sure we did an excellent presentation before, but we know that cardiovascular mortality kind of has a bimodal distribution. So in the initial, acute phase, or at least an acute diagnosis, it's usually because of, increased activities at the beginning or uncontrolled lupus disease. But, after the 10 years, so when someone has lupus for 10 years or more, their cardiovascular risk now is increasing with myocardial infarction, stroke, and peripheral arterial disease. This was a nice, so the forest graph to the left is kind of like a nice meta-analysis that I came across. Again, a lot of problems with studies looking at SLE is that it's grouped with other rheumatological conditions, and so our power into is not as great, and also issues with kind of sample size. But certainly, SLE increases in most of these studies 2 to 10 times risk of cardiovascular disease. And why is that? So a multitude of factors. So immune dysregulation, and that really cardiovascular disease is a inflammatory response, right? Inflammatory response that happens in your blood vessels. Steroid use, prolonged and protracted steroid use are associated with increasing cardiovascular risk factors, so diabetes, hypertension, and also just systemic inflammation. So I found this interesting. Lupus itself increases risk of cardiovascular risk factors. So, the traditional cardiovascular risk factors like hypertension, diabetes, dyslipidemia, and specifically the reason why there's a circle in one of them is that, again, this meta-analysis had actually shown an association of SLE with a twofold increase in hypertension. And the problem with a lot of these studies is there are a lot of heterogeneity. So, different populations, different measures or measurements. So it's kind of difficult to interpret. And this meta-analysis was only 17 studies. And certainly this also targets towards the need for OR restratification in the Caribbean, especially because we have a high burden of lupus nephritis and lupus. We kind of went through, I'm sure we've gone through some of the lupus specific factors. So long-term disease duration, usually more than 10 years. Lupus nephritis is in bold and underline. Neurological disorders, high disease activity, organ damage, use of glucocorticoids, antiphospholipid antibody positivity. And then you have your traditional risk factors, because remember, our patients are living longer with lupus, right? So because we've gotten so much better at treating them, so older age, family history of cardiovascular disease, again, hypertension, and other traditional risk factors that they may have. Black race may be associated with an 18-fold increased risk of CVD. So this was a poster presentation actually at ACR out of Atlanta, and they had a registry of SLE patients who they followed up. And they actually found that patients who were African-American had higher rates of cardiovascular disease compared to their white counterparts. And again, the same kind of meta-analysis of 17 studies, of which 4 had lupus nephritis and CVD outcomes. Because of the heterogeneity of the studies, they actually found that, I should say there was a twofold increased risk of cardiovascular disease, and this is defined as myocardial infarction and stroke. Again, the problem with these studies is a problem of heterogeneity in defining what they meant and the study populations. Lupus nephritis increases your risk of myocardial infarctions, three times increased risk. And this is from data from a large Danish cohort. And importantly, there's an 8-fold increase of mortality associated with cardiovascular disease compared to non-renal SLE. So people with lupus nephritis have higher risk compared to people living with SLE who do not have lupus nephritis. And why is that? So again, all goes back to the kidneys. So in people with kidney disease, there are a lot of things that happen with your blood vessels, which cause oxidative or a damage. So one thing is that there is endothelial dysfunction in kidney disease, again, because of dysregulation of or increased pro-inflammatory factors, which happens with chronic kidney disease over time. Additionally, there is left ventricular remodeling. A majority or up to 80% of people with any form of chronic kidney disease, specifically 3 and above, have left ventricular hypertrophy. And this is thought to be related to a multiple of factors, including hypertension, vascular remodeling from, again, increased adhesion molecules and upregulation of aldosterone or upregulation of the renin-angiotensin system. Additionally, remember, people with kidney disease have risk factors for kidney disease. That's why they have kidney disease. And those risk factors are also the same as cardiovascular disease. So the last thing, it has to do with kidney function. So uremia itself, so the uremia is the buildup of toxins from kidney dysfunction. And these uremic toxins may play a role in both in both a pro-inflammatory state and also causing direct vascular damage. So how does lupus kind of add or subtract to this? So one, the therapy for lupus. So steroids, for example, high dose steroids cause insulin resistance. They also increase water and sodium retention and hypertension. All these things are bad from a cardiovascular outcome, right? There is immune dysregulation. We know that a lot of cardiovascular disease happens because of the immune dysregulation at level of the endothelial cells and the heart. And the association of lupus with hypertension, especially in people with lupus nephritis, as well as vascular dysfunction, and just systemic inflammation, which happens with lupus as well. We used to think that the endothelium was just a conduit for blood, but it's actually not. It's very metabolically active. And there's a lot of adhesion molecules which are involved in the inflammatory response that occurs with cardiovascular disease, specifically coronary artery disease and peripheral vascular and cerebrovascular disease, which is upregulated in patients with lupus nephritis. There are some biomarkers that have been come in favor. And again, these are just very small observational studies, platelet-derived endothelial cell adhesion molecules, vascular endothelial cadherin, which are associated with development of lupus nephritis. Because when you think of lupus nephritis, there is a lot of kind of inflammation complement regulation, but there's also endothelial dysfunction, which occurs in the kidney as a result, or which leads to lupus nephritis. And it is thought that the signaling cascades involving these biomarkers are dysregulated in lupus nephritis. So essentially what I'm saying is the same process that leads to lupus nephritis may also cause vascular damage. There may be some promising markers or biomarkers for lupus nephritis, and these may also correlate with cardiovascular risk. We're not sure yet, and certainly this is early data. So kind of going back to clinical assessment, so sorry. Risk assessment in lupus nephritis, as anyone treating anybody with lupus, we all recognize that the traditional risk equations underestimate cardiovascular risk. This was an interesting study that I came across from out of Canada that showed that of their 1,243 patients with follow-up, they had 90 major adverse cardiovascular events and 211 secondary events. And what I found was the duration of lupus disease activity, the creatinine, meaning people with higher creatinines and positive double-stranded DNA, increased risk on adjusted models. And this always highlights the need of clinical assessment tools, especially from Afro-Caribbean populations, which risk may be different and are often underestimated in a lot of these big trials. So what's the future? The need for validated clinical risk assessment tools. What's the role of novel biomarkers? Because we're gearing towards kind of precision medicine, like what is your individual risk? And the more recently, which is actually from this author, May Choi, the role of AI and machine learning using clinical and biomarker activity to predict risk. So back to our patient. So I actually calculated her ASCVD score, and it's really low. It's 10 years, it's 3.1. But in my mind, when I saw her, and this may not be evidence-based, she has CKD, she has albuminuria, and she has moderate albuminuria. She's had lupus for more than 10 years. She's Black, which I assume everyone thought she was, but she is Black, FYI, and she's obese. So I kind of came across this paper when I was looking up stuff for her, and she was like, and I recognized that a lot of people with lupus, even if they have a low risk, are not being treated with statins. We're not very good with statins, because when she came to me, she was not on a statin. And even people with secondary, so they've had a risk factor already, they're either not on an appropriate dose of statin or they're not on a statin at all. So that's really important for us to recognize the importance of kind of risk modification. So I started her on a moderate intensity statin. I started with 20. And we recommended like lifestyle modification. So weight loss and exercise. And it's really important because exercise in and of itself, independent of weight loss, improves kind of cardiovascular outcomes. And not out of the scope of this talk, but I started her on an SGLT2 inhibitor for two reasons. One is progression of kidney disease, but also cardiovascular risk. Because at 55, with hypertension, CKD, and SLE, I thought she was higher risk than the score predicted. So that's kind of the end of my presentation. If you have any questions, I may not be able to stay until the end of the segment, but that is my Twitter handle. You can DM me, or my email is present. And thank you.
Thank you so much, Dr. Fisher. Such a fascinating talk, and so interesting to learn about the interplay between the immune system, the kidney, and the heart, and to realize that in our patients, we can't necessarily take their age at face value, okay? So as Dr. Fisher said, she is unable to stay. So if you have questions, we'll share the email in the chat. Please feel free to email her. So we're going to move right along to our second speaker, Dr. Rohan Wilkes, who will be talking to us about the evaluation and management of cardiac conditions in lupus patients. And now Dr. Wilkes, he received his Bachelor of Medicine, Bachelor of Surgery, and Doctor of Medicine from the University of the West Indies. He then went on to do a fellowship in clinical cardiology at the University of Toronto in 2016. He currently works as a consultant physician in cardiology at the Kingston Public Hospital. He's a consultant cardiologist at Winchester Cardiology and also at the Heart Foundation of Jamaica. He's an associate lecturer in the Department of Medicine at the University of the West Indies, an executive member in clinical cardiology at the University of Toronto in 2016. He's also an executive member of the Association of Consultant Physicians of Jamaica. Now, for those of us who know Dr. Wilkes well, we would know that he would not miss an opportunity to attend any purple-themed event, being a proud graduate of the Kingston College. Thank you for that applause. He's an astute clinician and truly a wonderful person. Dr. Wilkes.
All right, thank you. All right, good afternoon, everybody. Thank you to Dr. Anderson for that wonderful introduction. And thank you to the organizers for giving me the opportunity to talk about this very important topic. Both Dr. Milan and Dr. Fisher spoke a lot about the importance of cardiovascular disease in the patient living with SLE. So there's a lot of overlap, but I think that just makes my job a little easier. And I'll just touch on some things from the cardiologist's perspective, and talk a little bit more about the other issues outside of atherosclerotic cardiovascular disease that patients with lupus will have related to the heart. So I'll just go ahead and share my screen. All right, there we go. See if this works. Okay. All right, so no relevant disclosures for this talk. All right, so well, I was going to start by posing the question, why are we talking about cardiovascular disease in this lupus symposium? But I think the two previous speakers and the Q&A kind of delved into that very well. But just to reiterate, the incidence of cardiovascular disease in lupus is very high. Studies show more than half of patients with lupus will have some form of cardiac manifestation of lupus or atherosclerotic cardiovascular disease. And not only is the incidence high, but it is responsible for high mortality, which we spoke about earlier as well. So one of the things that has happened, and I think this was touched on a little bit earlier, as the rheumatologists have gotten better at managing lupus with improved therapies, patients with lupus have been living longer. So we have improved survival over the past several decades, whereas in the 1950s, we had a 5-year mortality as low as 50%. Data more recently show that the 5-year survival is as high as 95%. So much improvement in the world of lupus, even though the rheumatologists will tell you that there's much more work to be done. But overall, there have been less deaths from active disease. But as a result of patients with lupus living longer, there are more deaths related to cardiovascular disease and other comorbidities. So when we look at the range of pathology for cardiovascular disease in the patient with lupus, so just like lupus can affect all systems of the body, lupus can affect all parts of the cardiovascular system. So we know pericardial disease is very common, as well as myocardial disease. We know valvular disease, not as common, but is seen in patients with lupus, and we're going to touch on all of these. We know there can be some conduction system disease or arrhythmias associated with lupus. We spoke earlier about the issue of thrombosis and the difficulty in differentiating thrombosis from atherosclerotic cardiovascular disease. And of course, coronary artery disease, we're going to delve into a little bit more towards the end of the talk. So first of all, let's talk a little bit about pericarditis. So pericarditis is actually the most common cardiac manifestation in the patient with lupus. Autopsy series show quite a high prevalence, as much as 83% of patients will have some evidence of pericarditis. Of course, a large number of these would have been asymptomatic during life. But we do know that there are, when the pericardial tissue is examined, there's a lot of deposition of immune complexes that kind of moderates the pathophysiology of pericarditis, as well as it's been shown that there is some predisposition from a genetic standpoint. So how do we determine if a patient has pericarditis? So the most common presentation is a patient presented with chest pain. And just like in the general population, it can be difficult deciphering what the underlying reason for chest pain is. The chest pain of pericarditis usually characteristically worsens with the patient lying supine, improves with them sitting forward. So that's a big clue. Atypical cases, the reverse can be true, where they get worse chest pain with sitting forward, relieved by lying down. And as well as there's usually a pleuritic nature to the chest pain. So if you have that type of chest pain in a patient with lupus, then that raises your suspicion of pericarditis. When we examine the patient, we specifically listen for a pericardial friction rub. And again, that's another clinical sign that this may be pericarditis that we're dealing with. We then move on to do an ECG, and we look for characteristic changes. There's usually diffuse ST elevation throughout both precordial and limb leads, as well as there may be PR depression suggestive of pericarditis. And then an echocardiogram is usually done in these patients, and mostly we're looking for the presence of a pericardial effusion. So the diagnostic criteria from the European Society of Cardiology suggests that any two of these four parameters, you can make that reasonably make the diagnosis of pericarditis. So this ECG just demonstrates the findings that we will see in pericarditis. I know the persons online may not be able to see this, but we have ST elevation in the limb leads as well as the precordial leads, quite diffuse. Also, the other clue is that these ST elevations are concave rather than the convex ST elevation that are more typical of acute ischemia or ST elevation MI. This ECG also demonstrates PR depression. We don't see this as much as the ST elevation, but it is another sign of pericarditis to look out for. So this ECG is actually from a patient that we had at KPH recently, and I included it again because we don't see this PR depression a lot, but quite extensive PR depression. You see the PR segment there, especially in the inferior leads, quite marked and obvious PR depression. And this patient had a very large pericardial effusion, actually developed cardiac tamponade, which is one of the complications of pericarditis and required urgent pericardicentesis. So along with those four parameters that we evaluate, and four of them making the diagnosis, we can also be clued in to pericarditis by the presence of inflammatory markers. We look out for leukocytosis. Moderately elevated ESR and CRP can also clue us into the fact that this could be pericarditis. Additional imaging is not usually necessary, but in some cases where the diagnosis is uncertain, especially with persistent symptoms, the use of cardiac CT or especially cardiac MR can help us to look at the pericardium and see if there's inflammation there consistent with pericarditis. Mentioned the complication of cardiac tamponade, potentially life-threatening complication. So it is important to get the echocardiogram, look if there are any echocardiographic signs of tamponade, and also the clinical assessment, looking out for hypotension and assessing for pulsus paradoxus to make the clinical diagnosis of cardiac tamponade and intervene early. As well as constrictive pericarditis and purulent pericarditis are less common but important complications to look out for. In terms of the management of pericarditis, high-dose steroids are usually effective in patients with SLE who have pericarditis. We tend not to use that first line for patients without lupus, but we're more aggressive in using high-dose steroids in the patients with lupus. In combination with non-steroidal anti-inflammatory drugs, and colchicine still has been shown to improve outcomes with pericarditis as well. IV immunoglobulin is not used in most cases, but in some severe cases or recurrent cases, it might be considered as an additive therapy to improve outcomes. And again, pericardicentesis usually only if there is hemodynamic compromise and cardiac tamponade would that be necessary. So now to talk a little bit about myocarditis. So myocarditis is not as common as pericarditis. more recent data shows a prevalence of about 10 to 30%. Myocarditis may also present with chest pain, similarly to pericarditis, but the patients with myocarditis tend to be more ill, more toxic looking. They can present with fever, tachycardia. They're more likely to present with hemodynamic compromise as well. They tend to have even higher ESRs than patients with pericarditis. Most times with pericarditis, you don't have an elevated troponin. You tend to have more marked troponin elevations with myocarditis, as expected, since the myocardium is affected and troponin is part of the myocardial tissue. You tend to have very high levels of troponin. So as you can imagine, in patients presenting with chest pain and elevated troponin levels, it can often mimic an acute coronary syndrome. And this is a problem we face in terms of differentiating patients coming in acutely with chest pain. Is this a myocarditis? Is this acute coronary syndrome? And I kind of liken it to during the COVID pandemic, when a lot of patients were coming in with myocarditis, we had that clinical dilemma as well. But these patients will have low C3 and low C4 as well, as a clue that this presentation is related to their underlying lupus. Echocardiogram, very important for these patients presented with myocarditis. A lot of them will have LV dysfunction. Typically, they end up with a global hypokinesis of the left ventricle, but we have seen where the myocarditis can occur in a more regional pattern and give regional wall motion abnormalities, again, mimicking ischemic process rather than an inflammatory process. Cardiac MRI is probably the best non-invasive test to confirm myocarditis in general and in patients with lupus. Not as readily available as echocardiogram. As it is now, I think we only have one center on the island doing cardiac MRI. But if we can access cardiac MRI, very helpful, highly sensitive and highly specific for myocarditis. But the gold standard for diagnosing myocarditis is actually endomyocardial biopsy. Now, again, this is very invasive, again, not readily available. But the guidelines looking at myocarditis in SLE suggest that once there's LV dysfunction and you've ruled out coronary artery disease, endomyocardial biopsy really should be pursued. But of course, this is not readily available and can be associated with complications. So in practice, a lot of times we base our diagnosis on the clinical scenario in conjunction with the echocardiogram. And if we can get a cardiac MRI to firm up our diagnosis, then that usually suffices. Myocarditis, they often need a lot of supportive treatment. Again, they often present with hemodynamic compromise. They can be in cardiogenic shock. A lot of these patients might need to be managed in the ICU, where they can get inotropic support, etc. Pulse steroid therapy should be given to these patients, and get a lot of good outcomes with pulse steroid therapy. In terms of additive therapy for further immune suppression, there's no clearly beneficial strategy, but a number of agents have been looked at in the literature, including cyclophosphamide, MMF, azathioprine, and a very small study I saw showed the use of rituximab in patients with myocarditis. So I included this echocardiogram image just to kind of demonstrate. Again, this is another patient that we saw at Kingston Public Hospital. I'm not sure why we don't have the slide on the screen. But, okay. All right, let's have a bit of it. Okay, here we go. All right, so I hope everyone can see this well. So this is an echocardiographic image. It's usually the first image to start with the parasternal long axis image. So this is the left ventricular cavity here. You can see the myocardium here, the interventricular septum, and the inferior lateral or quote unquote posterior wall, both looking quite hypokinetic. They usually look more brisk than this. Importantly, there's a large echo-free space posterior to the left ventricle, representing a pretty large pericardial effusion. So this is a patient that was just 20 years old, diagnosed with lupus, referred from a peripheral hospital with chest pain and symptoms of heart failure, shortness of breath, severe orthopnea, etc. And when we did this echocardiogram, it was actually her second presentation. She presented previously large pericardial effusion, heart failure symptoms, chest pain, responded to therapy, and then represented in severe heart failure. But on the first presentation, did not have LV dysfunction, but on this presentation had significant LV dysfunction. I think her ejection fraction was about 43%. So we see anteriorly where we have this pocket of fluid, 1 centimeter, and then posteriorly quite a large pocket of fluid, 3.1 centimeters. So this confirmed that she had a large pericardial effusion. So at this time, she did not have cardiac tamponade, but later in the presentation, she did develop cardiac tamponade and needed urgent pericardiocentesis. We see a little bit of valvular dysfunction here with that blue jet representing mitral regurgitation, a little bit of aortic regurgitation there as well. So this is the short axis view. And again, I think demonstrating well this large effusion around the heart. And again, this is the apical 4-chamber view. You see the pocket of fluid here. So at this time, as I said, clinically she wasn't in tamponade. We tend to look for any inversion of the right atrial wall, which might suggest that the intrapericardial pressures are, overcoming the intracardiac pressures, causing tamponade, which, as I said, is life-threatening and would need urgent pericardiocentesis. All right, so just a little bit on valvular disease. Not up to 75%. Again, this is on autopsy series. Patients show that they have some amount of valvular involvement. Again, a large amount of these patients would have had asymptomatic valvular disease, only 18% being symptomatic, and only 1 to 2% being hemodynamically significant that would need any intervention with valve replacement or valve repair. The Liebman-Sachs endocarditis has long been described in patients with SLE. The mitral valve is most commonly involved. And again, a lot of them are asymptomatic, but they do have to be monitored for progression. And if they become symptomatic in the face of severe regurgitation, then they might need surgical intervention. A lot of this is due to immune complex deposition, and it's believed that the antiphospholipid and endothelial antibodies lead to platelet aggregation and thrombus formation on the valves, leading to these vegetations and subsequent valve dysfunction. Patients with long-standing SLE are more likely to develop Liebman-Sachs endocarditis, and again, there's an association with antiphospholipid syndrome, so these patients are more likely to develop it as well. Again, there's no established medical treatment. It's been looked on if added immunosuppression can prevent the progression. This has not been shown to be beneficial. So basically we'll monitor, and if it becomes hemodynamically significant, then the patient may need valvular surgical intervention. Just a little bit on conduction system disease. So mostly it's related to the development of congenital complete heart block in the face of neonatal SLE. So mothers with high titers of anti-Rho have a risk of passing on those antibodies to the fetus, leading to complete heart block. So it usually happens in the second trimester because that's when antibodies are passed across the placenta, as well as that's when the cardiac conduction system is developing in utero. So because of that, fetal echocardiogram is recommended in patients with SLE with high anti-Rho titers, so we can monitor for fetal bradycardia. They're particularly at high risk of poor outcomes if the fetal heart rate is below 100. Hydroxychloroquine has been shown to be beneficial, especially in reducing recurrent events of a mother who has had a fetus with fetal bradycardia and complete heart block before. There's data to show that the incidence of it happening a second time is reduced with the use of hydroxychloroquine. And of course, if the neonate develops complete heart block, then they need to have a permanent pacemaker. Thrombosis, I won't spend too much time on this, but this is related to the antiphospholipid syndrome. We spoke earlier about these patients are at high risk of thrombosis. A lot of times it's difficult to tell what's thrombosis and what's atherosclerotic disease. But if antiphospholipid syndrome, usually diagnosed when there is recurrent arterial or venous thrombosis and or fetal loss in the presence of antiphospholipid antibodies or circulating anticoagulant. And patients with the confirmed syndrome who have had thrombotic events should be anticoagulated with heparin or warfarin. So now we're going to go into coronary artery disease. So a lot of this has been said before, but atherosclerotic disease accounts for a large amount of the mortality. Up to 25% of the mortality related to SLE will be related to cardiovascular disease. When you look at age-matched women, so 35 to 44-year-olds with no lupus versus those with lupus, there's as much as a 50-fold risk of them developing coronary artery disease. So massive increase in risk just from having lupus. In terms of fatal MI, patients with lupus are 3 times at risk of developing fatal MI. So very important for us to be aware of this and try and identify cardiovascular disease early so we can intervene. I think Dr. Fisher touched on a lot of this. Well, she mostly spoke about the immune complex deposition, but there's also dysfunctional HDL that plays a role in the atherosclerosis in patients with lupus. We know that HDL, or the quote-unquote good cholesterol, is usually protective because of its antioxidant effects. But the patients with lupus actually develop dysfunctional HDL, which become pro-atherosclerotic and increase the risk of atherosclerosis, as well as antibodies are developed towards the HDL, as well as the apolipoprotein, which is a part of the HDL. So all of this works together to increase atherosclerosis in patients with SLE and increase their risk of myocardial infarction. Again, this was touched on earlier, the role of chronic steroid use. So again, steroids does increase the incidence of diabetes, mellitus, dyslipidemia, and hypertension, which all work together in increasing atherosclerosis. So in terms of evaluation for CVD risk, it starts with our clinical evaluation. So patients with lupus, we should always ask about angina. And I think we all know what typical angina is, retrosternal discomfort, either retrosternal or left-sided discomfort, usually described by the patient as a pressing or tightening sensation, which may radiate to the shoulder, jaw, or arm on the left side. But we have to remember that angina can happen anywhere between the ear to the navel. So not all patients will present typically. We also know that women in particular tend to have atypical presentations. And we know most of our patients with lupus will be women. So we have to maintain a high index of suspicion when patients complain of chest discomfort. And then they may have anginal equivalents. So sometimes they're having angina and it doesn't present as chest discomfort. Sometimes it's just dyspnea or feeling of shortness of breath or fatigue. So after, again, a high index of suspicion, take these symptoms seriously and evaluate accordingly. We're always on the lookout for risk factors, modifiable, which we're going to go through shortly. And we always look out for other things, history of family history, which may clue us into a higher risk in this patient, which we may have not identified if we hadn't asked. So this is a schema looking at some of the risk factors that we need to address. Studies show that up to 21% of patients with lupus smoke. And we know that smoke cessation is essential in reducing cardiovascular risk. We know the importance of cholesterol as well. So patients really should have annual fasting lipids. Generally, we start screening for dyslipidemias around 40. Again, there's no data, but it's probably prudent to start screening patients with lupus earlier, so we can detect any abnormalities earlier and intervene. We spoke about the weight, monitoring the body mass index, trying to achieve a body mass index of about 20 to 25. And there's growing data to show that waist-hip ratio and other similar measurements may actually be of more benefit than measuring the body mass index. And then the blood pressure really should be checked at every visit to monitor for the development of hypertension. And then if they do have hypertension, there is a recommendation that if the lupus nephritis is present, that the ACE inhibitor be used in preference to other agents because of its renoprotective properties. So again, this has been spoken about earlier, but this is the ASCVD risk calculator from American College of Cardiology. So those are the parameters there. We do encourage everybody seeing patients to use these calculators. We know that they're likely to underestimate risk, but they're still a useful tool to give us clues when patients are at higher risk so that we're more aggressive with our interventions. So just to illustrate, we actually put in some numbers here. So we see we're a 45-year-old woman with relatively normal blood pressure, reasonably normal lipid profile with no diabetes and a lifelong non-smoker will come out with a low ASCVD risk score. So that's a 1.8% 10-year risk of having a cardiovascular event, as opposed to a woman that's a little bit older, 59, with elevated blood pressure, a low HDL and high LDL with diabetes will come out at high risk. So this is somebody who would definitely need to be more aggressive with interventions than the previous person. I put this here. So this is the WHO risk chart. This is what is in the current screening guidelines from the Ministry of Health. So we should be aware of it. It's a little limited because it uses total cholesterol and doesn't look at the LDL and HDL fraction, but it's designed to be utilized in a setting where we may not be able to get HDL and LDL, so we still are able to calculate, estimate risk in these patients. All right, so what can we do to reduce CV risk? So Dr. Milan spoke about AHA's Essential 8. So I won't spend too much time on this, but I think AHA has done well to kind of package the number of things that we can do to reduce CV risk. So diet is essential in terms of, and won't go too much into detail, but more fruits and vegetables, less sugar sweetened beverages, etc., as the Heart Foundation has been trying to tell us, and avoid trans fat totally. Increased activity goes for the general population, goes for the patient with lupus, at least 150 minutes of moderate exercise per week. And we know that, sitting is the new smoking. So we want to, stay active, stand up, don't sit all day. As I was preparing this, I remember at KPH, anytime I go to see Dr. Tollereed in the clinic, she's never sitting. She's always standing, seeing patients. And I think she's mindful of the risk of sitting while she does that, I think. Or she's just hyperactive, I don't know. Or just busy. I see. Again, we can't stress this enough to avoid tobacco. Sleep, Dr. Milan highlighted this, the importance of sleep. 7 to 9 hours is the sweet spot. Less than that is bad. And there's evidence that more than that can be bad as well. Manage weight, we touched on that as well. Managing blood sugar, we spoke about that. So a fasting blood glucose annually to look out for impaired fasting glucose or diabetes and then intervene as necessary. We spoke about blood pressure as well and controlling your cholesterol. So this is from the ESC guidelines on dyslipidemia. So the main thing I just wanted to highlight is that there is a class 1 indication to use your risk scores. So that's a must. We have to start using our risk scores to try and estimate risk. We're not just looking at cholesterol in isolation or blood pressure in isolation. We put everything together and estimate the patient's risk. And then once you do have dyslipidemia in the context of elevated risk, then you want to intervene. So this chart kind of outlines, how we approach the risk estimation. So this is risk score versus the actual lipid levels. So basically, the higher your risk score and the higher your lipids, the stronger the indication to intervene. So we'll see where even if you have abnormal cholesterol and your overall risk score is low, you can still go with lifestyle modification as opposed to somebody who is known to have atherosclerotic disease. Almost it doesn't actually matter what your cholesterol is, you will benefit from being on a statin. So that's kind of the schema we work with when approaching the use of statin and other lipid-lowering therapies. So again, Dr. Fisher kind of touched on this. So if in primary prevention, we try to aim for LDL lowering of about 30 or so percent. So a moderate dose statin, such as atorvastatin, 20 milligrams, 10 to 20 milligrams is adequate, or rosuvastatin 5 to 10, as opposed to when we're talking about secondary prevention, so somebody who has established atherosclerotic cardiovascular disease, or in somebody who is deemed very high risk, then we want a LDL reduction of greater than 50%. So we'll go for a high intensity statin, atorvastatin 40 or 80, or rosuvastatin 20 to 40. So like Dr. Fisher said, there's a lot of issues with patients not being on a statin when they should be on one, or being on an inappropriate dose of statin. So we have to, adhere to the guidelines and make sure we're reducing risk effectively. Just a note on cardiovascular imaging, Dr. Milan touched on this. So not very strong indications. We see there is a 2A indication for carotid ultrasound to look for atherosclerotic plaque, and a 2B indication for CAC scoring. I think it can be beneficial, especially in someone who is borderline or moderate risk, to kind of further refine their risk and make a decision. And I think especially the CAC score I find useful in somebody with abnormal lipids. They're low risk. They're not a strong indication for a statin. Sometimes patients are still very anxious, and I think them seeing that their CAC score can be reassuring to them, even though they still have to be aggressive with lifestyle modification, etc. All right, so just to talk a little bit about the electrocardiogram. I'm not sure how I'm doing with time. But so there's not a strong indication for screening with ECG, even though we tend to do it in practice. But when we do a ECG, mostly if there were some symptoms or if we think somebody is very high risk and want to be aggressive with screening, some of the things that make us worry are if we see pathological Q waves that might indicate that the person has had a previous event that we didn't know about. Significant ST depression makes us worry and want to do further intervention. Or a left bundle branch block is another ominous sign that we'd want to look further at. So just to touch on stress testing a little bit. So certainly if there were some symptoms or were some signs on the ECG, then we want to progress to stress testing to try and establish the diagnosis of coronary artery disease and help to risk stratify them. So these are some of the indications. I won't spend too much time on that. And then, so our stress modalities can either be exercise or pharmacological. So usually once a patient is able to exercise, we should employ a exercise stress modality. This chart kind of just shows us the sensitivity and specificity of exercise testing with and without imaging. So the regular stress ECG has pretty low sensitivity and specificity of 68 and 77% respectively. As opposed to when you add nuclear imaging or add echocardiogram, the sensitivity and specificity goes quite high. So the guidelines still say that if you have a normal resting ECG, you can employ just regular exercise stress testing. But in practice, would tend to be aggressive in using imaging, especially in women who can have a lot of false positive ST changes on stress testing. All right, so that's just an ECG showing significant ST changes. That's reiterating the point we made before. If the resting ECG is abnormal, we should use imaging, either echo or nuclear. Just had some pictures demonstrating an abnormal stress echo. We'll just go by that in the interest of time. This is a nuclear imaging showing a defect in the anterior wall with stress, suggesting ischemia in that area. And there's a little bit about pharmacological stress testing, which we use in patients who are unable to exercise, whether it's severe arthritis, patient may have had an amputation before. Then we use pharmacological stress testing. Dobutamine is what's most readily available locally. Again, we'll go past that. So from this slide, it's really just reiterating what was said before. So normal resting ECG, you can use an exercise treadmill, whereas if it's not normal, we should use cardiac imaging, and you can choose exercise or pharmacological stress testing. If it's normal or mildly abnormal, then we just continue with risk factor modification. But if it's moderate or severely abnormal, then there should be on guideline-directed medical therapy. And especially if the EF is low, then that patient might have to go to PICJ for cardiac cath. Again, kind of a schema just to take you down to the different kind of stress testing. Just to highlight here that there can be a role for CT coronary angiogram, especially if your stress test is equivocal. You can use a CT coronary angiogram to kind of decide if there is significant coronary disease. And just to say, if you do have an abnormal stress test and find out the patient has stable CAD, so in order to reduce the risk of them having events, you want to get that person on a antiplatelet drug. Usually aspirin is first line, clopidogrel if they don't tolerate aspirin. And again, they should be on high intensity statin therapy to help reduce their risk. So just to close, some take-home points. So cardiovascular disease is extremely common, accounts for a high level of mortality in patients with SLE. When we look at cardiovascular disease in SLE, there are conditions due to the active disease, and then the atherosclerotic cardiovascular disease in more long-standing lupus. We have to have a high clinical suspicion. Sometimes we have to pay attention to very subtle symptoms, so low threshold to, stress these patients to try and uncover significant coronary artery disease. Early preventative measures are key. Remember our essential 8, they're essential. Use our risk scores, estimate risk, and when they're high risk, we intervene by addressing their blood pressure, getting them on a statin therapy to prevent their risk of developing cardiovascular events. All right, so thank you.
Thank you, Dr. Wilkes, for such a comprehensive talk. We are a little behind time, so we're going to head straight into questions. Dr. Wilkes, how useful is requesting CRP for cardiovascular assessment in patients with lupus?
Okay, thanks for that question. Thanks for that question. I think Dr. Milan touched on this earlier, because patients with lupus may have baseline elevated CRP. It takes away from the specificity of it being elevated. So I don't think it's very useful in estimating cardiovascular risk. I think we'd have to rely on other clinical parameters. Like Dr. Fisher said, if you have a patient with target organ damage like chronic kidney disease, you look out for peripheral arterial disease, work out the risk score. I'd more rely on those parameters to estimate risk than the use of the CRP.
Okay, thank you. So we now know that SLE can cause accelerated atherosclerosis. So for our younger patient with lupus who comes to the emergency room with chest pain and the troponins are elevated, how do we approach that patient in terms of differentiating whether this is a myocarditis or an acute ischemic event?
Right, so that can be difficult. So in terms of diagnosing an acute myocardial infarction, we always look at serial troponin levels. So a single elevated troponin is not diagnostic of an acute MI. So with the high sensitivity assays that we have in most places now, we really should do a troponin on admission and then repeat within 3 hours. And we're looking for at least a 20% rise as indicated by the universal definition of MI. So if there's at least a 20% rise in the troponin in the context of chest pain that is suggestive of ischemia, I think it's safer to treat presumptively as an acute myocardial event. And then your evaluation down the road can really decipher if this really was so or not. But because of the high risk of poor outcomes from this and the need for urgent intervention, I think significant elevation, fall or rise in troponin in the context of chest pain in a patient with lupus, I think should be treated as an acute myocardial event until proven otherwise. Now, again, these patients may have myocarditis, which can present with chest pain and elevated troponins as well. So we have to be mindful that, we might be seeing a myocarditis in these patients. So if the person can get a coronary angiogram, then that would be more definitive in differentiating an acute myocardial event from acute myocarditis. And then if the angiogram is not suggestive of an acute MI, then we can try and go on to a cardiac MRI to confirm the myocarditis.
Okay, thank you. Another question. How long do you continue colchicine for a patient who had pericarditis, who continues to have elevated inflammatory markers and a persistent effusion? This may be more a question for me, but...
Yes, that's right. We tend to defer to the rheumatologist in terms of the medium to long-term treatment of these lupus-related manifestations. So I don't know if one of you guys want to respond.
Right. So remember that pericarditis, it's another disease manifestation, it's a flare. And one of the ways we treat flares is we administer immunosuppressive medication. So for these patients, you've tried maybe NSAIDs or colchicine and they have been ineffective, then we move on to one of our more conventional disease modifying agents. Okay. There are a lot of questions I see about antiphospholipid antibody syndrome, quite a complex area. And some of it is beyond the scope of this talk, but to address some of the questions right now, in terms of the use of a DOAC or a NOAC, if a patient does have a venous event or an arterial thrombotic event, then we tend to use warfarin primarily for the treatment of these events.
Right, just to piggyback back on that. So we know DOACs have revolutionized the treatment of thromboembolism in general, but the data so far actually shows that it increases the risk of thrombotic events in patients with antiphospholipid syndrome. So at this time, still not recommended in that subgroup of patients. Yes, Dr. DeCula. I think Dr. Tollereid had a question as well.
Comments on what question I actually lost the patient. Okay, mic is on now. Unfortunately, I actually lost a patient one night that we'd been trying very hard to treat for a flare because she developed chest pain in the night and the on-call team gave her heparin. So her pericardial effusion transformed to a hemorrhagic one and she seemed to have lost the battle. So, just questioning about, as you mentioned, the issue of whether all patients, with acute chest pain and so on should make sure to have an echo before they're anticoagulated. And I do appreciate that point you're just making about the role of warfarin for the lupus patient with antiphospholipid syndrome, that the regular ones may not be protective in a patient antiphospholipid syndrome. So my question, I had two short questions. One was, seeing that the traditional Framingham risk factors don't seem to work in our population, they don't satisfy those requirements all the time. At what level do you start a statin in a lupus patient who's not having symptoms? Is there? I know for diabetes we have a sort of threshold. Do we have one for lupus? And I also wanted curiosity whether cardiologists check antiphospholipid antibodies.
Well, for the first question, again, there's not a lot of data. There is one recommendation because lupus is thought in some circles to be a cardiovascular disease equivalent, sort of similar to diabetes. So there is one recommendation to kind of approach it such as diabetes. So we know that when you have atherosclerotic disease, your threshold is very low to start the statin. With diabetes, it's low, but not as low. So generally speaking, along with your risk score, if the LDL is more than 2.6, then we usually intervene in a diabetic at that time. As Prof. Tollereid is here, he can back me up or say I'm wrong. But yeah, there's a recommendation to use 2.6 as well as a cutoff for LDL in lupus. I saw in at least one review paper to kind of treat it as an cardiovascular disease equivalent, similar to diabetes. So that's one potential approach that will lead us to intervene earlier in the patient with lupus compared to the general population who would use the quote unquote normal cutoff of LDL, which is more around 3.5 or 3.6. That's one potential approach. And cardiologists test for antiphospholipid antibody when indicated.
Yes, Dr. DeCula.
Yes, Dr. Wilkes, this was a very good lecture, but I suddenly have a problem. I have a lot of patients, quite a number of patients with high HDL cholesterol 1.82/2, and now you're telling me that these patients have probably a dysfunctional HDL. How do I know if the HDL is functional or not functional?
Yeah, that's a very interesting and difficult question. So actually I don't know the answer to that. I see I think their experimental attempts to try to type and examine the HDL. But as far as I know, there's nothing in clinical practice to kind of decipher when there's HDL is functional or dysfunctional.
May I make a brief comment? I don't know if Dr. Asana is going to, but what I saw last is that the data has not indicated that the HDL is particularly protective in the lupus patients. It seems as if having a high HDL may be commonly found, but it does not appear to be protective in patients with lupus.
Thank you. And I believe this closes this segment. Thank you so much, Dr. Wilkes. Thank you, the audience, for all these very interesting questions that have arisen. Mr. Smith?
Well, before you go too far, Dr. Wilkes, certainly, I'd like to thank Dr. Wilkes, Dr. Rowan Wilkes, and Dr. Asana Anderson for what was really a very engaging session. We actually went over time, I didn't even realize it. And it sort of prompts me to think that, can you imagine when the second session starts, and we have things like the panel discussion and the more patient-friendly segments, I can just imagine what's going to happen. But for now, I'd like to ask Ms. Abayumi to make a presentation to Dr. Wilkes. Dr. Wilkes, again, thank you very much. Very good presentation. Thank you. Sorry for going over that.
Thank you, sir. On behalf of the foundation, we appreciate your
Dr. Wilkes, you're not leaving, are you? I'll have a question or two for you after, but not to worry. Well, ladies and gentlemen, again, I invite you to ensure that you're here for the next section. We will be starting at, we'll be giving you, I'm generous, I'm going to give you 10 minutes. Should it have been less? Anyhow, 10 minutes it is. And we'll be starting with the second section. And of course, you can look forward to, which will be starting at exactly 1:15. Yeah. So again, I'd like to thank our major sponsors, Partners Interventional Center of Jamaica, and our booth is also over there. And of course, we'd like to recognize the presence of our gold sponsor, Medical Products Limited. And of course, again, thanks to platinum sponsors Wysinco, National Health Fund, IPCA Laboratories, and the Barita Foundation. Right. We have adequate facilities to eat and drink outside. So may I remind you that we do not encourage eating and drinking inside, but we'd encourage you to go outside. And as I do recall Dr. Wilkes saying, I think Dr.
Hi, I'm Dr. Victor Elliott. I'm an interventional cardiologist, and I have been practicing for over 60 years.
Here's a good opportunity for us to,
which means I've had experience
in thousands of angiograms, ladies and gentlemen, and be prepared for that very exciting patient-friendly segment. Thank you very much.
Hi, everyone. I'm Georgia. I'm 25 years old and I have lupus.
Hi, my name is Jada Marie Graham, and I am 19 years old, and I have lupus.
Hello, my name is Umiko Chin. I'm a final year student at the University of the West Indies, and I have lupus.
Hello, everyone. I am Anike Suarez, 36 years of age, and I am a lupus warrior.
Hi, my name is Kiana Jackson, and I'm 19 years of age. I was diagnosed with lupus when I was 15 years old.
Hello, everyone. My name is Rishan Brown. I'm 14 years old. I attend Meadowbrook High School. I'm in grade 9. Lupus has affected me a lot.
I was first diagnosed back in 2017 in September after having a common cold that wouldn't go away and also some enlarged lymph nodes on my neck.
I've been fighting lupus for 5 years now. I was diagnosed with lupus in 2016 at the age of 15 years old. Leading up to me being diagnosed with lupus, I would have, my symptoms were having constant headaches, hair loss, swelling in the joints, my knees, my hands. If I stand too long, it would be a problem. If I'm writing, it would be a problem.
Okay, so I was diagnosed at 16. A lot of things are still a blur, but from what I can remember is I suddenly got sick. I kept throwing up, just throwing up. Everything I ate just kept coming up. And I took a trip to the doctor. Now, the doctor said that it was probably meningitis or some other things I don't remember, but I know I took a series of tests and I was told that it's not lupus. It's probably just a stomach bug or something. And I went home and I kept throwing up again. And I saw a kidney specialist and then I did a ANA test and then it came out negative.
Just getting fatigued, exhausted by just even doing the little things was of concern to my parents. So one day I got up, it was a Saturday morning, and I had rashes. And then we went to our general doctor and she, did the regular general checkups and stuff. And then she said that the rashes are of concern for her and she's going to recommend me to see a rheumatologist.
Lupus, well, for me, it was always letting my joints swell up. I always feel pains. Sometimes I would ask my mother, she would ask me if I hit it up or anything. I was like, no, I didn't. And she was so confused. And that was happening for years. And, she was really concerned. as any parent would be.
Yeah, Wednesday after school, went to see the rheumatologist, Dr. Stacy Davis. I know she was asking me if I ever heard of lupus, and I was like, no, doctor, what is that? And then when she began to explain and blah, she began to explain and she began to tell us what it is, and all my symptoms was aligned with what she was saying. And then all the blood tests for the blood work that I did before visiting her, they all came back positive for lupus.
I remember going back to the Turks and Caicos Islands where I'm coming from, and I remember passing out one night. I went to the hospital there, and then the last thing I remember was being flown into Jamaica to the University of the West Indies, where I met a rheumatologist, Dr. Maloney. And that's when I found out, yes, it is indeed lupus. And I was further treated for that.
I did not know what lupus was. I had lymph nodes. I was experiencing joint pain, fatigue, and I was tested for cancer. And the test came back negative. A few months later, I had the lymph nodes reappearing, and then I met my rheumatologist, and she told me that I had lupus.
I was first diagnosed with SLE lupus at the age of 17. However,
Fourth annual Lupus Symposium that has been going from 9:30 this morning. I'd like to invite all the persons on the outside to come back in to make their way in very quickly so we can start another exciting section, which of course will be spirited by Dr. Hagley and Dr. DeCula. But of course, I would like to also thank and recognize our kind sponsors in the likes of Partners Interventional Center of Jamaica, Medical Products Limited, Wisynco, Barita Foundation, the National Health Foundation, and of course, I'd like to invite you also to stop by the booths that are right here. The Lupus Foundation of Jamaica booth, very well outfitted, very well stocked with items that you can have to wear to rep the LFJ Foundation, and also to donate and to find ways in which you can help in supporting the foundation in its growth and in its work towards helping all the lupus patients in Jamaica. And of course, the booth of the Partners Interventional Center of Jamaica is here, and Medical Products of Jamaica Limited as well. The start of the second half of this evening's section will be with what we consider to be bridging the gap. Now, to start us off, I'll be inviting Dr. Carleen Hagley, consultant rheumatologist at the Spanish Stone Hospital in Jamaica, and she will introduce Dr. Karel DeCula, And we will be looking at what is considered to be a more patient-friendly segment. And if you recall how the last segment finished, very engaging. I can almost imagine that this one will be just as engaging. So without further ado, I'd like to invite Dr. Caroline Hagley to the lectern and get us started in the section that speaks of bridging the gap. Dr. Hagley.
Thank you, Mr. Smith. Well, welcome back, everyone, present and online, to our session 3, Bridging the Gap. It is my pleasure to introduce our next speaker, Dr. Carol DiCullo. Many of us know him. Officially, he graduated from medical school in Leuven, Belgium, and went on to do his specialist training in rheumatology in Holland, the Netherlands, at 2 main locations. He also had further rheumatology training in Glasgow, Scotland, and Paris, France. And he subsequently came to us in Jamaica in the late 1970s, where he joined the Faculty of Medicine, teaching at University of the West Indies, which he continued as an associate lecturer over many decades. In 1980, he joined the Medical Research Council for sickle cell disease, where he remained active until 1991. He has been a long-standing consultant rheumatologist at the University Hospital of the West Indies, and as I mentioned, an associate lecturer at UWI. Of this association, the Lupus Foundation of Jamaica, he was president for a long period of time between 1995 to 2013, and he remains our president emeritus. He has participated in research, published several articles and reviews, and we are all aware that he has dedicated his medical life of service to patient care, teaching, and has helped to advance rheumatology practice both in Jamaica and the Caribbean. Many of the rheumatologists who have come out of Jamaica and the Caribbean over the last 40 plus years see him as a mentor, and he has influenced all of our lives wherever we have gone throughout the world. And without further ado, I'm going to invite Dr. Carol DiCullo to speak to us on lupus medications and the heart, what a patient should know. Please welcome.
Thank you, Dr. Hagley, for these kind words, and thank you all for inviting me. I am here trying to... This is just a timer, so when I start waffling too much, I can control myself, or this device will control me. So today we're speaking about medications, because medications is important that we understand what they can do for us and what they also can do that we don't like them to do. So when it comes to the heart for lupus patients and medications, there are 2 concerns. Basically, there is a concern about prednisone, and there is a concern about painkillers like anti-inflammatory drugs. So prednisone, of the corticosteroids, we have a couple of them. Most people know the prednisone, but some people, some lupus patients who had low platelet counts, they can remember that for 4 days they would take dexamethasone in high doses, which tend to alleviate thrombocytopenia. If you are unfortunate to have to go to hospital, you probably get, with a flare, you get an infusion of methylprednisolone. There is the last steroid, which is basically the Flasacort Calcort, for which the brand is unfortunately no longer available. People looking at it, but there is an Indian generic that is available, so you can ask your pharmacy to find out where you can get it. I know Dolphin Pharmacy has it. So the people who feel good on Calcort and not so good on prednisone, they can find it there. Prednisone is essential. We all want to get rid of it, but recent studies show that if you stop your steroids too quickly, too rapid, you would actually end up in a flare. So the whole idea is to reduce it very slowly. But prednisone is important. It is actually around quite a long time. In 1960, Doctors Kendall and Hensch got the Nobel Prize for their work in cortisone. In fact, the steroids were a war effort because the English and American pilots had observed that the German guys could fly higher and longer than they could. Also at the same time, the CIA found out that the Germans were buying some adrenal glands of cows in Argentina. And so they put the 2 and 2 together and start fractioning the thing. And that is where these steroids were discovered. So anyway, unfortunately, prednisone has negative effects. It increases blood sugar, it increases blood pressure, cholesterol, it makes the blood more liable to clot. But what all people know on steroids is that it puts on weight. And the next slide will show that unfortunately the way that it puts on weight is causing a more central put on weight. You see, the kind of middle of us expands. The lady at the right-hand side has a more peripheral obesity, which now the central kind of fattening is the one that is dangerous for the heart. So basically, if you have to put on weight, you want it to be on the behind and not on the front. And so the next slide, this is the big belly man that you see. So basically, we should all try to get a circumference that doesn't exceed 38 inches for men and 32 inches for women. I don't know. Anyway, this, if you ever go for Miss Jamaica, you have to have less than 28 inches or less. Otherwise, the Pegasus will not take you for the kind of thing. Prednisone, apart from weight gain and all the other things, also affects the heart rhythm. And so the heart can go too slow, too high, too rapid, or being irregular. And the way that prednisone does it is it changes your electrolytes, your potassium, your sodium, your calcium, and not to forget your magnesium. Low magnesium levels, which are induced to the fact that we don't eat enough green vegetables, the prednisone will drop it down even more. Now, prednisone, as long as you are taking up to 5 milligrams, 1 tablet a day, it doesn't seem to do too much damage, as you can see from the slide, the top line. The hazard ratio 1.1, oh, we can live with that. But if you go over 6 milligrams, you see that the numbers are going high. But this is not the only problem with prednisone. Prednisone also, next slide. Prednisone also, yes, prednisone also accumulates, or the dose that you take accumulates. It's like the lady, the cashier there, every time you pop a prednisone, she will tick it in her system. So over time, you acquire a whole heap amount. Now you can see here, you could, if you take 2 prednisone a day, after a year, you have accumulated 3,000 milligrams of prednisone. Now, who cares? That's not so much. Because when it really matters, when you have accumulated 35,000 milligrams, which is a whole heap. Now, it could be a whole heap, yes, that is 10 milligrams every day for 10 years. But if you have a flaring, you have to go, unfortunately, to hospital, and you get 5 days of methylprednisolone, which is 5,000 milligrams, the clock starts ticking. And so basically, lots of people, if they're not careful, reach the figure of 35,000 milligrams too quickly. And then some cardiovascular damage and other organ damage can occur. Next. So what to do? You always try to find a minimal dose of prednisone. That is, some people do better with taking the prednisone every other day, because the lupus get treated with, say, a double dose, and this puts all these inflammatory cells a bit down. And by the time now, the next day you don't take any, so when they start plotting again to give you a warm time, you get again a good dose. So that in some people seem to work well, and it cuts back on the amount of prednisone that you take. Also, we used to give people for flares, we say, okay, flare 40 milligrams of prednisone. And when the flare is over after 2 weeks, we used to say, okay, now you go to 30 milligrams, then to 20 milligrams for 2 weeks, then to 15, then to 10. And if you add this all up, it's a whole heap of steroids. Lots of people get away with just, after the 40 milligram, go down to 20 for 3 days, to 10 for 3 days, and you might reach your 5 milligram daily very quickly, and you save on the prednisone. This also depends on the underlying activity, but if you don't know, you don't know. So if you don't try, you don't know. So this is a way to do it. And another thing is, lots of my patients say, I didn't feel this morning, I didn't feel so well, I had some joint pain. I took 2 extra prednisone and my joint pains were good. You should try to take something else for the joint pains instead, so that you not depend fully on the prednisone. So that is something. If there is anything else you can do, do it. So that is the prednisone. The other bad guys, or possibly bad guys, are the anti-inflammatory drugs, which are very good for joints. Yes, they can cause your stomach to be upset. They can reduce kidney function, but fortunately, if we discover it and you stop it, it's usually reversible. The thing with allergic skin rashes is an issue which is very difficult, because it's atopical eczema, or whatever they call it, from and non-steroidal anti-inflammatory drugs seems to take a long time to resolve. And so now, after a while, is this a lupus rash or a medication rash? It's very difficult to find out. Now, on the heart, NSAIDs can raise your blood pressure. If your heart is not too strong, it can actually induce heart failure. And if you take it every day, it makes you more susceptible to MI, to heart attack and stroke. Next. So what to do? If you have blood pressure issues, you have to come off it. If you get swollen ankles with fluid retention, you have to come off it. You should not use the anti-inflammatory on a daily basis. Use Panadol as much as you can, or if necessary, in combination with codeine, so the Panadol or Cetamol or the Panadine and the Cetadine. And then sometimes you can use anti-inflammatory drugs. Now, the other medications, the immunosuppressive, which is in the next slide, all of them, fortunately, they don't affect the heart. Azathioprine, methotrexate, mycophenolate, rituximab, they don't affect the heart, so we don't have to deal with them. Now, what about our medication that all of us need to take, which is hydroxychloroquine? Hydroxychloroquine is said that anybody who can tolerate it and has lupus should be on it. So because people on hydroxychloroquine, they live longer, they have less flares, they have less kidney disease, nerve inflammation, cholesterol, and the sugar is down, and they get less thrombosis. So that is all good. But of course, there is no free lunch in life. So we have to check the eye from time to time, because the hydroxychloroquine can accumulate in the eye. In the beginning, it upsets the stomach, but if you start low, that is not a problem. It can give skin rashes, which tend to be on the sun-exposed areas. But what is the situation with the heart? Now, the situation with the heart was never an issue. We rheumatologists were just doing our thing and were writing prescriptions. But then COVID came along, and there was this mobster called Donald Trump. I don't know if you have heard of him. And he was promoting hydroxychloroquine as the cure of COVID. And then there were some accidents that I didn't know if it was the hydroxychloroquine or it was the COVID itself and whatever. And suddenly, rheumatologists were said that you have to be careful with it, something that for decades had never been a problem. So what is the effect of hydroxychloroquine on the heart? Now, this we have listened to it before. I just put it up just to show that anything that hydroxychloroquine could do, the lupus can do as well. And so it's very difficult in studies now, because you can hardly find enough people who do not take hydroxychloroquine. So you never will have a good control group because it's difficult to find them. So what can it do? So we have the valve. We don't have to see this slide now. Let us go to the next one. The next slide. Next one. So this is what lupus can do. Now let us see what hydroxychloroquine can do. And it could, just like it can accumulate in the eye, it can accumulate in the heart muscle, which could theoretically give you an enlarged heart, which lead then eventually to heart failure. There is no test that can show if the chloroquine is accumulated in the heart. It is just an estimation. The only test that we can do for accumulation of chloroquine in the heart muscle is doing a biopsy, but I don't think that you're so keen of having somebody sticking a needle in your heart. I wouldn't do it myself. I would just try to figure out, this is not different from the eye doctor. The eye doctor puts you in front of this machine, the OCT, which is an ultrasound, and they do a retina thing. And when they feel the retina doesn't look good, they conclude it must be the hydroxychloroquine that caused it. But there are many other reasons that this retina wouldn't be too happy, but it's an assumption. I don't think you're going to find any eye doctor who's going to stick a needle in somebody's eye and take out a piece of the retina and send it for biopsy. I don't think so. So we don't go and do any pieces of heart either. So now, theoretically, hydroxychloroquine can also interfere with the electric impulses of the heart, which would give you a slow heart rate or an irregular heart rate. And that could be seen on the ECG easily by measuring the QT interval. Next. Now, since lupus, that is the chicken, can cause these things, and hydroxychloroquine is the egg, which is the chicken and the egg. In fact, there should be two eggs because the other egg would be the prednisone. So which one is which one? And that is very difficult to decide on. Dr. McGee, who is the consultant in Montego Bay, did a lot of work in looking at electrocardiograms in people on antimalarials on long term, I think. She was studying people who took more than 1,200 grams, which is about 17 years if you take one tablet a day, and 8.5 years if you take 400 milligram, 2 tablets a day. And although there was a trend of accumulation in people who took more than that, it was not really significant. The significance is how long your lupus lasts, so which says it's not the medication, but it's the lupus. And of course, people who basically had kidney function. And we had already learned from Dr. Fisher that the kidney treats the heart very badly. The conduction abnormalities, the slow heart or the irregular heart, actually was noticed in people who took hydroxychloroquine for a long time, but they went on taking it and the abnormalities improved, showing that it's lupus again, the chicken, not the egg, that causes the problem. And so that was very interesting work by Dr. McGee. So basically, there are only a few people who should actually be wary about hydroxychloroquine treatment. If you have been taking it for 15 years, 20 years, you have a heart failure, and the heart doctor is tearing out his hair or her hair because he can't understand why you have this heart failure. It's wise to give hydroxychloroquine a holiday. Patients who have irregular heartbeat or very slow heartbeat, an ECG is easily done. It doesn't cost any money. We can do the QTC interval and see if the hydroxychloroquine is doing something to the conduction. The only thing is if you are on other medications, together with the hydroxychloroquine, which can prolong the interval, the QTC interval, then you might do an ECG a little earlier. which are these things, these medications. You have, of course, the antifungal. All the antifungals can prolong the QTC interval. And the thing is that it would be very sad that for a toenail that is infected by fungus, which you could actually cover with some nail polish, that your heart starts stopping and being erratic. So I would not combine the antifungals with hydroxychloroquine. The antibiotics usually no problem because you only take them for a couple of days. Now the Lexapro, the quetiapine, the risperidone, that is taken for a longer time. Yes, maybe once in a while we should check the ECG. Motilium is sometimes taken, but people don't take it for long. But if you were living in Neverland, like Michael Jackson used to be, and you can afford a 24-hour doctor who's in the next room where you are, tell him not to inject you with propofol, because that didn't Michael Jackson. I don't know if Michael Jackson was on hydroxychloroquine. I heard some rumors that he had lupus in the time. Maybe he was taking that, but he probably could also have taken some of these psych medications. I'm sure he had some of that. Now, these are the medications. What vitamins do you do for the heart? Now, all of us should take omega-3 fatty acids. The only thing you have to do is try to get the purified thing. You see on the label if it's purified, otherwise it might contain heavy metals. But also recently it came out that you should avoid anything that's, say, high potency omega-3, because the industry is actually doing something to the molecule. They take off the backbone of the molecule, put some other things in it, and that is then leading to irregular heartbeat and atrial fibrillation. And so if you see concentrated or whatever, just stay away from it. It's one of those things that is not good for us. Vitamin D we should have, folic acid helps, and magnesium is very important. Now, unfortunately, the common magnesium that you're going to find in the pharmacy is magnesium oxide. And magnesium oxide is not absorbed at all, 4%. So it's a waste of time. So you should try to get magnesium taurate or glycinate, or these are the better choices if you can find them here. My friend, Mr. Amazon, will basically have them for you anytime you want it. I will say something about CoQ10. I wouldn't advise it for the simple reason, again, CoQ10 is not absorbed very much. So you might just wasting your money. And the reason for that is that the company that or the industry that really makes CoQ10 is a Japanese company, and it is made in a crystalline kind of way. These molecules are crystallizing, and the body cannot absorb the crystal. The body can absorb the individual molecule, and the molecule want to crystallize, so no absorption or very little absorption take place. Now, you could say, I see some advertisement on the cable in which there is a company that produces ubiquinol, which is the reduced form of CoQ10. And so they say, oh, it is better absorbed because theoretically the reduced form is better absorbed. However, when they check it, while the vitamin, the CoQ10, is sitting on the shelf or on your dinner table to be consumed, it's oxidizing every second to ubiquinone, which is not readily absorbed. So basically, if you want to take CoQ10, take the lowest dose, the 50 milligram, because you spend less money. Of the 50 milligram, 10 milligram may be absorbed. If you take an expensive one, 200 milligram, 10 milligram will be absorbed while throwing away money. Since some generation ago, our ancestors cut down the money tree, and it was the last one that was available. We have to watch out for the money. Basically, heart-friendly diet. I think fiber is the most important one. I notice some people are gluten sensitive, so the slide not entirely is appropriate for some people, but for the rest, fiber is the key. Thank you very much.
You can have a seat if you want, Dr. DeCoola. Thank you, Dr. DeCoola, for making your talk patient-friendly. Are there any questions from the floor? I don't think I've received any from online chatters so far, unless there are any still to be sent. Any questions from the audience? Dr. Anderson?
It could get a cardiomyopathy by accumulation. But in Dr. McGee's study, it was only one person and had, no, 3 persons had an enlarged heart. And it was not even sure if it was the hydroxychloroquine, and they were asymptomatic. So I wouldn't worry too much about it. Thank you.
Any other questions? Prof. Tollereid.
I'm coming back to the figures that were shown where you had a higher cardiovascular risk around the lupus patients. And now that the discussion has continued for the day, the role of medications like NSAIDs and steroids on increasing cardiovascular risk, I think, are becoming more evident. I didn't know if you had any thoughts on how much of the excess cardiovascular risk might be a result of treatment versus attributable to the disease itself.
Yes, that's an interesting question. I always am fascinated that we know that lupus inflammation is bad for the blood vessels, and therefore prednisone, which is the real effective anti-inflammatory medication, should be good for the blood vessel. However, that doesn't seem to be so, at least. And I think it is dose related. I think if you take 5 milligram of prednisone, your blood vessels would be good for longer than if you go over the 5 milligram. And that's what the slide showed. The other medications, I don't immediately think that they matter that much. But we know that prednisone, even if with their effect on lipids and diabetes and all that would be the problem. Now, the thing is that where we haven't gone is genetics and prednisone. And I have a kind of feeling that some people are more vulnerable than others for taking prednisone.
Thank you.
Any other questions? Feel free. You can introduce yourself if you wish.
I'm Mildred Marsh. I'm a lupus patient. Dr. DeCool, I'd like to ask you, I'm supposed to take the prednisone in the morning, 5 milligrams, but I don't feel comfortable with it in the morning, so I take it at night. But I cannot sleep after taking it.
Now, can I ask you a question? How quickly the speech recovers?
Sleep.
Oh, sleep. No, but that is basically that is a well-known fact. And unfortunately for you, but fortunately for most people, 5 milligrams doesn't seem to be too bad. But if you go to the 10 and 20 milligram, sleep is really impaired. And that, I think, is one of the reasons that one is advised to take the prednisone in the morning. Now, this is different from rheumatoid arthritis, where the patients can't sleep because they have morning stiffness and pain that starts at about 2 o'clock in the morning. And if they take the prednisone at night, they get better. So basically, you have to find yourself. Everybody is different. If you have joint and muscle symptoms at night, you might feel better in taking the prednisone at night. But if you have a sleep problem, then you take the prednisone in the morning.
There's a question that's come through. Not sure if it's specifically Dr. DeCoola can take a pick at it. On YouTube, their question says, does lupus contribute to noticeable weight loss? I'm not sure if that is associated with other medications or if this is a delayed question coming.
Yes, lupus flares are associated with weight loss. There is also weight loss caused by malabsorption, by inflammatory changes in the duodenum and intestines, which actually I've seen people losing a lot of weight. Weight loss in autoimmune disease tends to be autoimmune activity of various kinds.
Okay.
Because I should also have said that if your thyroid goes out of order, then of course you will lose weight with overactive thyroid.
And I guess also if you've been on higher doses of steroids and had gained weight, maybe as those doses are being tapered, you may also be losing weight. So other things to keep in mind. You know, questions sometimes patients want to know, I have all these medications, the list increases. How long do I need to stay on some of these medications for? Some it may be specific to the particular complication. So for example, you know, persons who happen to develop lupus nephritis and have a prolonged period of higher doses, they may wonder, how long do I have to stay on these doses? I'm tired of taking it, and sometimes they reduce the dose and then we see them flare. And the understanding, anything else you want to shed with respect to that? Patient says to you, how long do I need to stay on these medications? I'm taking 2 tablets of hydroxychloroquine and 4 tablets of mycophenolate for my kidney problems. How long?
In many cases, the blood works will guide you to see if we can reduce the medications. And so if the blood works look good, we tend to reduce them. And then it's yourself who have to speak to yourself and say, body, how do I feel today? Do I take not enough medication or do I take too much medication? So it's your own feedback is very important.
Okay, thank you. I think if there are any other questions that come in online, we can probably see if we can get them redirected to Dr. DiCulo and have that addressed. And so this will bring to an end our session 3. And we thank Dr. DiCulo for his presentation. And I think someone is coming forward with a little gift, so don't go too far. And thanks for your attention.
I'd like to thank Dr. DiCulo and of course, Dr. Hagley for getting us started here on this section that speaks to the patient-friendly aspects of management of lupus. At this time, I'd like to also ask Dr. Asana Anderson to make a presentation to Dr. DiCulo. And also, again, extending my thank you for the presentation, which was quite simple, quite easy to understand, well, for me. And I thought it was very, very informative. Thank you very much, Dr. DiCulo. Preferably. Thank you very much. Thank you, Dr. DiCulo. Thank you, Dr. Anderson. And if there are additional questions, please feel free to send them in and we will have them addressed by Dr. DiCulo and all other doctors in the previous sections that the questions may be related to. And that's for most of the persons that are on our Zoom and our platforms online. So do not hesitate to send them in. So I think we have actually done fairly well so far. Not the greatest on time, but I think the information has been extremely rich and extremely enlightening. So our next section really will be preceded by some videos that will be speaking to patient experiences, the journey that many of our patients have been through, basically the perspective that the patients have had while they're on the journey of the lupus and lupus management. So I'll ask our technicians to cue that up shortly. And of course, I'd like to thank as well Mr. Kevin Jackson, who has helped tremendously with editing and preparation for a number of the videos. And Ronaldo Lewis has been working tirelessly as well. I'd like to publicly thank him, both himself and Kevin Jackson in this area. So we'll be seeing very shortly some patient perspective series and of course some of the experiences of our lupus warriors and of course some comments of their own as it relates to cardiovascular health. Right on cue. Thank you.
Looking at my experience, perhaps I shared with somebody else before, I could have prevented the heart attack. I therefore recommend that we share as much as possible with our doctors and with a trusted friend. That way we can ensure that we keep the best health. That's it.
They also did the lupus test on me to see if I have lupus, which all of them came back to be negative. I think I put myself in a position where I brought on additional stuff on me because I was not taking the medication as it was prescribed to me. I would take it when I want to, or when I see the blemishes start coming up on my skin again. I was then told that I had ITP. There's a long definition for it, which I don't want to say stupidness, so I'll just tell you it's ITP, which they say it's basically low platelet count. So there's no real reason why the platelets just get low sometimes. And even when you're on medication, they do get low from time to time. I should also mention that I have chickens and goats. So if you hear them in the background, they just want to be a part of it. By 2013, everything was just going great from 2008. And 2013, all of a sudden, I went to the beach, and on my way home, I just started feeling ill and went to the hospital where the platelet count was going crazy again. And also my hemoglobin went from 9 within a matter of 2 days, went from 9 to 2, which if anyone knows, your hemoglobin for females should be at 14.
First question. Have you ever heard that persons with lupus have a higher risk of heart disease?
Yes, I do. Yes, I have heard. So as a lupus patient, you need to take care of what you much caring what you eat, because that will affect your heart.
Have you ever heard of any specific heart problems that can occur with people with lupus?
Yeah, you can get a stroke, and get heart attack, and stuff like that.
Not, I know there would be problems with the heart because lupus can affect the heart also, but like you would say, heart failure and stuff like that, I don't.
Do you know if inflammation plays a role in how lupus affects the heart?
Yes, it does. Because when your infection is up, then it can just affect just about anything that is happening with your heart.
Yes, inflammation have a part to play, yes, but I guess because of your body not keeping up to par with the medication or stuff like that, then that will happen.
Are you aware of any lifestyle recommendations for lupus patients to protect their heart health?
Oh, wow. Just try and eat. Exercise. That is one very important thing. Exercise and watch what you eat.
Well, follow instruction from the physician about what to do and what not to do, and eat properly and so. But other than that, there's what is to be must be.
Can you name any common symptoms or warning signs of heart issues that lupus patients might experience?
Pain in the chest, short of breath, lack of sleep, together.
Do you think more information is needed about lupus and the heart?
Yes, I think so. That at least you can know what to expect, and what you see, you can act on it, and knowing that, well, this is perhaps the heart or stuff like that.
This year's symposium is focused on lupus and the heart. What do you think about that?
That's a good topic, and that's very good, because we need to know and be more aware of what is happening to especially our heart, because that is That is the life. Your heart is life. So we need the more, the merrier.
What else do you think that we should do to help people protect their heart and their circulation with lupus? What do you think that we should be doing more?
I think that maybe we should do more natural stuff, more natural juice and stuff like that. We focus mostly on the natural stuff that will help to protect or build our immune system.
Straight from the voice and the hearts of our lupus warriors. And as you would know, many of our lupus warriors engage with the Lupus Foundation, our centers at 7 Barbados Avenue, for those who didn't know, but I'm sure you already know this. And of course, some of the other features that I want to sort of bring to your awareness includes our celebration of World Lupus Day, which is usually in May. And of course, Lupus Awareness Month, October, where we try to have a number of activities to bring the awareness and improve the awareness of lupus within the society, including of the Lapsa Lupus event, and of course, this very special symposium, all held in the month of October. We have a number of other educational programs, including sessions for medical professionals, and which is geared towards improvement and detection and treatment. Of course, the CME facilities or the CME requirements or the CME possibilities that you get from attending the symposium is also one of the benefits that medical professionals will get. And our learning center, as I mentioned, at 7 Barbados Avenue, provide a lot of information, a lot of literature that can be shared and utilized pretty much every day of the week. So feel free to come in. And of course, our website, lupusfoundationjamaica.org. Feel free to view that website, stop at that website, recognize all the information you can get. Our booth is at the bottom here where you can actually engage with our representatives there. You can actually get a lot more information on lupus, information on how to donate, how to contribute, how to really become a lot more involved in what is happening. We have ways which you can donate online, and there's the interbank transfer. I think our bank account is 33202956. Don't ask me how I remember it by heart, but I guess it's part of what I do. But yes. So we do interbank transfers, and you can actually go online to lupusfoundationjamaica.org and make transfers or make donations. So lupusjamaicafoundation.org/donate. Stacey knows it by heart, so not a problem. And of course, yes, we have been also involved in securing funding and for critical equipment with different hospitals. We have worked and partnered with the National Health Fund in providing subsidies for healthcare for a lot of our lupus patients. Because as you do know, the medication, where's Dr. DeCula? The medication, as you mentioned, is can be a little expensive, quite a modest comment, but it is true. And we have worked very tirelessly with the National Health Fund to provide this. So again, they're one of our sponsors, and again, we thank them as well as the Partners Interventional Center of Jamaica and the Medical Products of Jamaica. So look at the back of your programs. You'll be able to see a lot of the information on our sponsors. But as we now move into the section that speaks to the panel discussion, our panel discussion will be, again, centered on patient-friendly type information. And I believe that this section as well, you'll get a chance to hear a very interactive session as it relates to that component and inclusive of treatment. So I'd like to invite to the lectern Dr. Stacey Davis, who will be taking us through this section. And I think Dr. Tomlin Paul she'll be introducing as well. Dr. Davis, please join us at the lecture.
I think I'm going to invite the panelists to come up. And as they're doing so, I'll introduce Dr. Paul. In I'm indeed delighted to introduce Dr. Tomlin Paul. He has been involved in the medical education of many of us who practice here in Jamaica as physicians. And Dr. Paul will be the moderator for the panel discussion, which is looking at lifestyle factors and a collaborative approach to preventing and managing cardiovascular disease in our lupus patients. So Dr. Tomlin Paul holds a Bachelor's of Medicine and Bachelor's of Surgery and a Master's of Public Health from the University of the West Indies, Mona. He later went on to complete a fellowship in chronic disease epidemiology at the Johns Hopkins School of Hygiene and Public Health in the United States of America. He's also a diplomat of the Faculty of Public Health Medicine, Royal Colleges of Physicians. For over 20 years, Dr. Paul worked in the primary care setting in Jamaica, where he served as family physician and director of Health Plus Associates, a multidisciplinary medical center, which he co-founded. He has also served as Dean of the Faculty of Medical Sciences, UWI Mona, and is currently the Deputy Principal of that institution. He has received several awards over his career, including the UWI Vice Chancellor's Award for Excellence in Teaching and the 5-Star Doctor Award for the North American region from the World Organization of Family Doctors. Dr. Paul has conducted research in health promotion and medical education, and it is an advocate for social accountability in health professions education. He is a fellow of the Academy of Medical Educators, UK, and a member of the International Society Social Accountability and Accreditation think tank. Welcome, Dr. Paul. I'll hand over to you.
Thanks. Thanks very much, Dr. Davis, and good afternoon, everyone. So let me say it's a pleasure to be here, to be moderating this event. I want to thank the Lupus Foundation for this invitation to be able to do so. And my only regret is that I didn't choose my purple shirt this morning. But yeah. So I think the foundation has been well laid. From the earlier sessions, we heard, I think all of the sessions have made the point that cardiovascular disease there's increased risk for cardiovascular disease in persons living with lupus. And we heard about risk factors, this complex milieu of risk factors. I think Dr. Lorianne Fisher spoke quite well about that interaction where there's lupus itself and all the inflammatory processes and so on presents that increased risk for cardiovascular disease. And then there's the traditional risk factors. And then there's the point she made that lupus actually contributes to traditional risk factors developing. And then there's the interaction with things like lupus nephritis and cardiovascular disease. So there is really a complex playing field or milieu of risk factors operating with respect to cardiovascular disease and lupus. So in addition, Dr. Milan this morning spoke about she warned us we should not forget the social determinants of health, because those are also operating in the backdrop. The economic, the social situations within which we live play a role in mediating some of these conditions. And she called, in fact, for a holistic approach. So how do we tackle risk factors? How do we tackle the issues that are not directly connected to the clinical treatment or the medical treatment or the medicine, but have a relationship in some way? And how do we deal with that from a lifestyle point of view? So this afternoon, we have 4 excellent panelists who are going to share with us their views on the lifestyle approaches. This session is titled The Lifestyle Factor and Collaborative Approaches to Preventing and Managing Cardiovascular Disease in Lupus. And certainly one of the big collaborative approaches we can put at the table is collaboration between the health provider and the patient. That collaboration has to be there. So we have 4 excellent panelists. I'm going to, they're going to have, how we'll do it, they'll have an opening statement, they'll make an opening presentation, and then we'll have some questions and answers and a discussion, hopefully a lively discussion on lifestyle factors that we can take home some points, both persons living with lupus, but also our healthcare providers can take home something that says, maybe I can do this way, or I should consider this as I go forward in terms of managing the reduction of cardiovascular risk and lupus. So I'm going to invite one speaker at a time, and I'm going to just give the introduction for each as they come up. So our first speaker is Dr. Marilyn Lawrence Wright. And Dr. Lawrence Wright is head of the Department of Medicine and head of cardiology at the University of the West Indies at UWI, Mona. She's a consultant cardiologist, and she is also a consultant cardiologist at the UHWI, where she serves as medical director of the cardiology unit and medical director of the interventional suite, and a consultant cardiologist at the Heart Foundation of Jamaica. Dr. Lawrence Wright obtained her Bachelor's of Science degree in biomedical engineering with honors and her Doctor of Medicine degree from Brown University in Rhode Island, USA. She has a Master of Science degree in clinical epidemiology and health services research from Cornell, and she did her internal medicine residency training at Johns Hopkins University in the USA. She also has advanced training in echocardiography, fellowship training at the New York Presbyterian Hospital, Weill Cornell Medical Center in New York, and she's a fellow of the American College of Physicians. She's currently president of the Caribbean Cardiac Society and represents them on the board of the Jamaica Coalition for Tobacco Control. She's also a past board member of the Association of Black Cardiologists. And through these organizations and her work at the Heart Foundation of Jamaica on the Global Health Advocacy Project has helped to advocate for cardiovascular health and to promote heart-healthy lifestyles. She strongly believes in the importance of patient education, empowerment, and participation in care. So she's very well placed, ladies and gentlemen, Dr. Lawrence Wright, to bring an opening statement, give her perspectives to us on lifestyle factors and management with respect to CVD and lupus. Let's welcome Dr. Wright Lawrence.
Thank you very much, Dr. Paul. Good afternoon, everyone. Congratulations to the Lupus Foundation of Jamaica, and thank you very much for inviting me to participate on this panel this afternoon. As you know, Dr. Paul has said, it's going to be an interactive session, but I did want to kind of make a few comments in terms of what patient-centered care looks like, particularly for the patient with lupus, and talking about cardiovascular risk and how we can reduce that among our patients. We heard quite a bit in terms of just how cardiovascular disease is increased in this population, and recognizing that risk, how we maybe try to moderate it. And I do want to speak to the HA kind of, life's essential 8, because I think that's a good place to start. And I think as we heard in the patient kind of, in the videos, we know that we know exercise, and I think we know that, and that what comes to the fore very easily. But I do kind of want to just mention the other 6, really, because, that heart healthy, that is important, yes. Exercise, or sometimes we say be more active, is important. But then also we need to pay attention to those known modifiable risk factors, right? So our blood pressure or sugar level, or weight or cholesterol levels, and certainly many of those you're not going to know about if you don't get screened, right? So the importance of screening to identify these risk factors. Now, one of the things about the patient with lupus, right? And how many patients do we have here in the room? Okay, excellent. You're already engaging in healthcare, right? Because one of the challenges for other patients is that they don't come to the doctor in the first place, and they don't come to be screened. You are already, engaged with the healthcare system, but just still want to emphasize the importance of screening for abnormalities in the blood pressure, the sugar, the cholesterol, recognizing whether you're overweight, as it is here, or a cultural norm, you may not know you're overweight. And we did speak this morning about the body mass index, and it does have its challenges in terms of accuracy of risk prediction and so on. But it's an easy way to kind of, determine whether you may be overweight or obese. And I don't know if our patients know how to calculate the body mass index. It's something you can do on your own. the weight in kilograms divided by the square of the height in meters. And there are ranges that are considered, but there are ranges that are normal, overweight, obese. So you really want to have your body mass index, BMI, be anywhere between roughly 18.5 and 24.9. Right? Once you hit to 25, you're overweight. And many of us are at 25 and we don't think we're overweight. And once you hit 30, you're obese, and both overweight and obese do increase your risk for cardiovascular disease. Also very important is abstinence from tobacco. That's not something that we readily talk about, but I think we should know that. And then of course, sleep, right? So healthy sleep, adequate and proper sleep. So not just the time in the bed, but really, are you sleeping and is it healthy sleep? Those are the 8 really, but I did want to add a 9th. And that 9th is, can anybody tell me what they think that 9th may be? Anybody in the room? Stress management, right? So stress management, I add as my 9th, and there are others that we could add, but I think that's very, very important and does interact with a lot of the other essential factors. I won't really say too much more at this point in time. I do have some other things I want to share, but I will just kind of maybe set a rubric that we can, refer to as you have your questions. In the sense being that when we're talking about patient-centered care, we have the patient, we have the patient's family and the patient's social network. We have the health professional who may be a physician, maybe a pharmacist, maybe a nutritionist, maybe a physiotherapist, health professional in some way. And then we have really the community, whether it be government, industry, all of these players are going to impact what happens with the patient. So certainly in from my perspective, that time that a healthcare provider has with the patient is very important in terms of empowering the patient, having the patient feel that he or she is going to participate in the care, has a responsibility, not just to just follow what the doctor says, but to do it because you really think it's going to impact how you feel and your possible outcome. Also empowering the patient's family, right? And sometimes patients come by themselves, sometimes they come with family members. Everybody needs to be in the conversation, and it's a conversation. So it's not just, you have this, that, we do this, that, and here's your prescription. It's a conversation based on what I've said. How much do you understand? How much do you not understand? In terms of making sure that the patient can identify the signs of heart disease, right? Our patients were able to say some of what they would expect, but certainly we know many of our patients with lupus are female. We have non-traditional, or not the traditional presentation of heart disease. So to really make sure that the patients can tell us, we tell them and they need to tell us back to make sure that they have an understanding and they've internalized and can act when they may or may not feel something. Also, just to highlight that, remember that there may be mood disorders at play, and we have to recognize those. Those are going to influence patient compliance and patient motivation to do what it is that we're recommending. So very important to recognize those. In terms of the community and industry, really just to say that, as Dr. Navarro Milan said this morning, and Dr. Paul just now, the social determinants of health, right? Up to 80% of the risk. And so we must see the patient in the context of the environment. And I would like to challenge all of us here, whether we be patients, family members, health professionals, government, industry, whoever we are, that we need to get involved in associations and organizations and foundations like the Lupus Foundation of Jamaica, because certainly we know that there's an advocacy role that makes the environment easier to kind of adopt healthy lifestyles. Right. So whether it be, tobacco legislation, whether it be healthy places to exercise, whether it be many options, affordability of healthy food options, all of these are things that we can help to move along if we take an advocacy role. So not just the individual interaction with the patient, but really trying to change the environment in which the patient functions. All right. Thank you very much.
Thanks very much, Dr. Lawrence Wright, and certainly setting the stage for that collaborative approach, bringing almost a kind of all of community approach to engaging the patient and ensuring that they can make choice and they empowered. So we're going to move on, colleagues. We have our next opening statement is going to come from Dr. Vanessa White-Barrow. Dr. Whitebarrow is a senior lecturer nutritionist and head of the School of Allied Health and Wellness in the College of Health Sciences at the University of Technology, Jamaica. She holds a PhD in nutrition, and she is the president of the Caribbean Association of Nutritionists and Dietitians, and a past president of the Jamaica Association of Professionals in Nutrition and Dietetics, a member of the board of directors of the Jamaica Island Nutrition Network, the Society of Nutrition Education and Behavior, as well as the Jamaica Statistical Society. Let's welcome Dr. Vanessa Whitebarrow.
Thank you, Dr. Paul, and thank you all for this invitation. I must also commend the Jamaica Lupus Foundation for staging this, what I consider very important event, especially this particular session focusing on particular concerns affecting our lupus patients. Now, when I got the draft program last night, I was a little, I wouldn't say put off a little, because I was thinking primarily of the role of the nutritionist and dietitian as part of the multidisciplinary team. But as I listened through the presentations and also to the patients, I shifted my focus a bit and I said, yes, the right theme was suggested for my opening. So I know that everyone here and online is quite familiar with the composition of the multidisciplinary team of health professionals led by our physicians, our rheumatologists, our cardiologists, nurses, of course, our pharmacists. But there are also the allied health professionals like the nutritionists and dietitians, the physiotherapists, the psychologists. And I want to talk a little bit more about that group, the allied health professional groups, because while we find that our physicians and our nurses, our pharmacists, they talk with each other quite often, it's very rare that the input of our nutritionists, our dietitians, our psychologists even, and our physiotherapists is an ongoing part of the communication. It does happen, but the extent to which it happens, and I think is something that this forum can really strengthen. I see it happening a lot in diabetes management, but here we are now looking at lupus, and we recognize that there are several concerns, especially for those that are affected with cardiovascular diseases. And looking at, just listening, first of all, to the patients a while ago, we hear concerns about poor self-image. You hear the self-blame, you go to the beach and you brought this thing about yourself. The depression that comes around when you see the prices of fruits and vegetables. The stress management that's so important. These are conditions, situations that our allied health professionals are highly competent to guide our lupus patients to better manage. In the case of nutrition and dietetics, which I had prepared to speak a little bit more of, I want to highlight a few things. One of the concerns many of us have, not just Jamaica, but probably globally, is that there's a tendency to use Dr. Google, which I'm sure is one of our patients' best friend, to sidestep some of these allied health professionals. The tendency is to go online and just download, a shopping list of things to do, list of foods to have, foods to avoid. Yes, we're fortunate that the kind of diet, for example, that is recommended for our lupus patient is actually quite similar to the one that is recommended for our cardiovascular and lupus and other inflammatory conditions. You want to reduce your intake of added sugars. You want to reduce your intake of fats overall, particularly your saturated fats, your trans fats. And of course, you want to increase your intake of fruits and vegetables. All of that you get from online. The shopping list includes foods like whole grains, lean meats, nuts, seeds, fats and oils, etc. But the thing is, when we as nutritionists and dietitians get them after they've gotten this shopping list, then we are faced with the frustrations that they really have. And we heard it coming out of one of the patients, just don't know what to eat. So yes, you give them a list of what to avoid and what to have, but they need more. And that is why the nutritionists and dietitians are so important to be part of this conversation. They need to know, for example, what whole grain foods are. I mean, we adopt this thing from the North Americans, eat more whole grains. But the truth is, in Jamaica and the other Caribbean countries, we're not a whole grain eating group. Yes, we eat rice, but the rice that we eat is white rice. Why? Because that's what we can afford. So when you tell them that white rice is really not a healthy whole grain option, because it is not brown rice. Then they ask, but I eat parboiled rice. The thing about parboiled rice, that is not brown rice either. So yes, it is part of the whole grain list, but it is rice, brown rice that pretty much has been partially cooked already. So that, when you eat the parboiled rice, yes, it does taste better, and it is a better option compared to the white rice. But really, when they're talking about eating the whole grain, when they're promoting that in the North American context, really what they're saying is eat more rice that is in the husk. And we tell them to the local consumers, they're like, really? Because it don't taste good, it takes longer to cook, And so they start to worry. I mean, so we need to also have a conversation with our clients that speaks to our indigenous foods, our staples, because you want them really to increase their intake of high fiber foods. That's really the goal. So you want them to have more vegetables. But then again, you have to face the reality that they're depressed when they realize, I can't afford vegetables. So you then have to have a conversation about, okay, what can you afford? What do you usually buy? And then you make those changes in your consultation with them. We also talk about how you prepare the foods. Again, that's a conversation that we really need to have. Why? Because what we're saying to the patient is pretty much like the way you've been preparing your food by using all this oil, you have to change that. Using all this salt, you have to change that. But then they're faced with the fact that, does that mean I'm going to have to cook a separate pot for myself, separate from the rest of my family? I can't afford that. So there are these realities that, we have to have a conversation about with the patients. Dr. DeCola talked about the supplements. That's another separate conversation that not just the patients, but even among ourselves as nutritionists and dietitians, we also have to have those discussions, because in terms of the kinds of recommendations, there are so many restrictions with respect to these conditions like lupus, for example, where you're telling them have more fatty fish. But the reality is these fatty fish, like salmon, they're not really part of our fish culture. So if I'm allowed to put it in that context, we eat sardines, we eat mackerel, but again, those options are usually in a tin. So salt has been added. So you have to then point out to them that, look, when you look on the shelf, there are different types of packaged sardines. There's the one in the water. There's the one in soy oil. There's the one in all kinds of sauces. So which is best for when and who can have that? So those are the kind of conversations that we have. So yes, there are times when you'll have to say, have more omega-3, which is not necessarily a bad thing. But no, people are realizing that persons are going out for the high potency ones. And persons need to know that not all omega-3 that are out there are equal. At the same time, can the patients afford them? So it goes back to food. So we have to think about the food part of the discussion and rely on our nutritionists and dietitians who are highly trained and competent to facilitate these discussions. And also there is the need for us to, help our patients to rely less on social media and realize that we do have experts locally. I mean, yes, we're encouraging our nutritionists, dietitians, and other allied health professionals to put themselves out there in the online space, but we also recognize that several of the patients, that they really need that face-to-face, one-on-one interaction. And if you're going online, make sure that you're credible. And that takes me to another part of the discussion, which speaks to which ones of the professionals do we need to go to? Because we recognize the training is different. And so you do have your dietitians, for example, who are highly trained, some more than others, because they would have spent more time in the clinical areas. And of course, as professional groups, and I heard my previous speaker speak to the importance of being part of associations, etc. You don't just get factual information, but when you're part of associations, you also have to maintain your continuing education. And that's an important part of why it is that I join these associations and I encourage others to join, because I want to ensure that the persons out there that are sharing information with the patients, that they're honest and they're adhering to certain codes of ethics in their practice, so you can trust the information you get from them. So that's how I would want to start the discussion.
Thank you so much, Dr. White-Barrow. So much for my white rice dinner after. Yeah. So we are expanding the collaboration. We have now our next opening statement is going to come from Ms. Cecile Hosang. Ms. Hosang is a physiotherapist who specializes in the management of chronic pain conditions. She has over 20 years of clinical experience working in a variety of healthcare settings in Jamaica and England. And much of her work has been with people who have long-term conditions. And she therefore uses a biopsychosocial approach to help them manage their conditions. Apart from chronic pain, she has extensive experience in the care of the elderly, falls prevention, musculoskeletal and neurological conditions. She qualified as a physical therapist in Jamaica at the School of Physical Therapy and has postgrad degrees from University of Brighton and the University of Edinburgh. In addition to clinical practice, she lectures at UWI, teaching a variety of sports and ergonomics courses. Let us welcome Ms. Cecile Hosang.
Thank you, Dr. Paul, and thank you everyone who's here. Thank you for having me. It's a pleasure and privilege to be here today. All right, so I'm here basically to talk about lifestyle approaches for the patient with lupus to reduce the cardiovascular risks or the negative outcomes, so to speak. And I think for physiotherapy and certainly for the way in which we want to work nowadays in healthcare, when it comes to lifestyle, the sort of the best way really is exercise. And if you don't like the word exercise, if it conjures up terrible images for you, you can use alternative, more politically correct terms such as movement, physical activity, anything along those lines. Because sometimes when we use or the patient hears the word exercise, it really can for some people have a negative connotation because they may think of lifting heavy weights in a gym with an instructor screaming and shouting at them. They can think of having to slog several miles of jogging or walking, which may just not be up their street. They may think of doing, repetitions, the physiotherapist. And if you're, physiotherapists, we're not very good at counting. So when we say we're going to give you 10 reps, we really mean 18 because we never quite get to 10. But, it can be, quite frankly, very boring sometimes, how exercise can be prescribed. But the thing with exercise is that in terms of the evidence base for any long-term condition, no matter what the diagnosis is, when it comes to things that a physiotherapist can offer patients, exercise usually has the best evidence base behind it. And it's just because simply we know of all the health benefits that exercise gives us. So in terms of cardiovascular outcomes, we're looking at everything. We're looking at things like you're going to get a better resting heart rate. You're going to improve your blood pressure, maintain or prevent hypertension over a long period of time. You're going to have an improvement in your cholesterol levels, a bad cholesterol, over a long period of time. And I keep saying over a long period of time, because again, sometimes patients or just everybody, we start exercising today and we kind of want to lose that 5 pounds in 2 weeks. But the very important thing to remember is that exercise takes time. All right. It's a cumulative effect and it takes consistency. And it takes time. So we're not going to lose weight in 2 weeks. We're not going to improve the heart rate or the hypertension in 2 weeks. It's something that we have to do regularly over a long period of time. And it's something that we need to do throughout our lifespan. All right. Other things that, exercise will do. Long-term exercise, we're going to get an improvement in the strength in the cardiac muscle itself. All right, we're going to get that better. The lungs are going to work better. So we're getting better oxygen uptake and the use of the oxygen when we're exercising. We're going to get better blood circulation. So anything that you can possibly think of from a physiological level is going to improve with regular movement, physical activity, and exercise. We're talking a lot today about inflammation in people with lupus and as a cardiovascular, negative aspect of cardiovascular diseases. Exercise is one of the best ways to reduce chronic inflammation in the body. I'm a pain management specialist. And chronic inflammation is one of the drivers of chronic pain. So if you have lupus, if you have your rheumatoid arthritis, if you have your regular osteoarthritis, whatever it is you have, yes, exercise can flare up your joint pain or your muscle ache, but over a long time, it's going to reduce that chronic inflammation. And you're going to find that generally speaking, pain levels are going to be reduced. We talk about stress. We talk about the depression, we talk about the anxiety. And again, regular exercise is going to help those outcomes as well. So if you're having a bad day, you go take a walk, a lot of the times you will feel better. If you are someone who has established depression and maybe need to take medication for the depression, or even if you don't need to take medication or don't want to take medication, regular exercise is going to help your general outlook on life, your general mental health, and the better you feel psychologically, the more motivated you will be or the more willing you will be to exercise. So the thing with exercise is that it really targets every aspect of our health. Every single aspect of our health. And once we start improving one part of the body or one system or the mind or the physical body, then everything else starts improving as well. And then all the negative outcomes or the negative effects or signs and symptoms of a lot of the diseases that we have will gradually improve. They may not be cured. We know that a lot of these things are incurable. And we know that we need the collaboration with all the different specialists. But if we're not exercising, we're really kind of not giving ourselves the best chances of having a good quality of life. So to everyone, both healthcare professionals and the patients, I implore you, as I say, don't necessarily think of exercise as something that always has to be prescribed 3 sets of 10 in a gym, structured. You can take a very broad, gentle approach, especially if you're just starting out. You can think of it as coming away from a sedentary lifestyle. Someone spoke about sitting is the new smoking, and a lot of us spend our days sitting. So if you even start with the approach of, I'm going to set a timer on my phone and get up every 20 minutes or every 30 minutes and walk around. I tell people all the time, even if you march on the spot for 20 seconds, every 20 minutes or 30 minutes, it's better than nothing. All right. Our children, all right. Our children nowadays are living a lifestyle that is just ridiculously inappropriate in terms of the sedentary aspect, the screen time. And I think we need to remember that screen time doesn't just mean the phone or the tablet or the computer. The TV counts as screen time as well. And even if the kids are studying on the phone or the laptop or the whatever it is, that counts as sedentary lifestyle as well. Children should be moving and playing and exercising several hours a day. Young children, teenagers, they say a minimum of an hour a day. I think that's not enough. But it's just to say as well that we live in a society now where the sedentary thing is normal. And our children, my child has grown up with that as being normal. And if it weren't for prescribed dance classes that she's a part of, she would do almost no exercise at all. All right. So we need to really start from early childhood, from the moment they can begin walking, crawling, running, whatever, throughout our lifespan. We get into our older adult years, middle age, we start to slow down. We need to phone a friend, start going for the walk in the morning, or, have Zoom classes, exercise classes with each other. We go into elderly ages. We think, grandma, don't move. You might hurt yourself. You might drop. You might fall. You're too old to do this. No, you must relax. You've lived you've worked very hard. It's time to retire. It's time to slow down. Don't discriminate against the elderly. They need to exercise as well. All right. And it's really important for them as well. No matter how old we are, we can get stronger. We can get fitter. We can improve all the things that a 20-year-old can improve by doing exercise. So just a kind of nutshell to say that it's important. It really is important for good quality of life. And it's not just looking at physical outcomes. We're targeting the psychological outcomes as well, overall health, and it goes for any diagnosis that someone might have. The lupus, the heart disease, the diabetes, neurological conditions, whatever it is. Thank you.
Thanks very much, Ms. Osang. Very convincing argument for movement. I won't say exercise, right? For moving. Huh? All right. Our final opening statement is going to come from Dr. Tamu Davidson. Dr. Davidson is the Director of Non-Communicable Diseases and Injuries Prevention at the Ministry of Health and Wellness, Jamaica. She has worked as a medical doctor and public health specialist for 27 years in both urban and rural Jamaica at every level of the health system, and most recently at the Caribbean Public Health Agency as Assistant Director for Surveillance, Prevention and Control, and Head of Chronic Disease and Injury Department. Her career in public health spans several public health programs, including health promotion, strengthening of health systems, surveillance, clinical guidelines and policy development and implementation on NCDs at national and Caribbean level over the past 20 years. Dr. Davidson is also a former lecturer in epidemiology and non-communicable diseases for the MPH program at the University of Technology, School of Public Health and Health Technology. Let's welcome Dr. Tamu Davidson.
Thank you very much for that introduction. It is certainly a pleasure to be here representing the Ministry of Health and Wellness. So I'd like to thank the Lupus Foundation of Jamaica. This is certainly a very, very important event, not only as a health professional, but also personally. So I'm here to talk about the strategies from the Ministry of Health perspective and from a policy perspective as it relates to addressing lifestyle conditions. And so at the Ministry of Health, I would say there are twofold strategies and approaches we have been taking, one at the population level, but also at the individual level. So at the population level, our programs have focused on really creating a supportive environment. So central to engaging in a healthy lifestyle is ensuring that you have the supportive environment to do that. So it's important to educate individuals about their lifestyle. And we're moving away from using the word lifestyle in many contexts because it connotates an individual only personal responsibility. But we know that whilst we focus on individuals and educating them about what they need to do to engage in the different lifestyles, as really covered very well by our first presenter in terms of the different risk factors, what is important is that there is the supportive environment for you to act on these lifestyles. So the key areas we have been focusing on for NCDs, both in Jamaica, in the Caribbean, and globally, has been around addressing tobacco use, which is a major risk factor for heart health. We've been working on improving diet, access to healthy foods low, not high in salt, fats, and sugars, because that's one of our challenges. And then we've been also looking at addressing the harmful use of alcohol and also addressing physical inactivity. And I will use the physical activity. We know exercise is structured activity, and but we'll use the physical activity term because we're trying to encourage people to move whatever they're doing. And so, and also addressing mental health and mental illness. And as mentioned before, persons with lupus face the ordinary risk that Jamaicans do from all of these risk factors. And of course, those are the behavioral risk factors. Of course, there's the obesity, the high cholesterol, the high blood glucose. All of these key factors are being addressed. And one of the contexts we have is the social determinants of health. So the way we live, work, and play is what's fueling these factors. And so the policy environment is the area that we've been working on. So one of our flagship areas we have been able to advance, and which we have seen some advances, is around ensuring that we have smoke-free public spaces. So one of the things as individuals we'll tell you and advise you about abstaining from smoking, but also we know that secondhand smoke is a major risk factor and exposure. And so we have the tobacco control regulations that through that regulation, we were able to protect over 2 million persons from just that particular intervention. And so we're also working on the comprehensive tobacco control law, which will help to protect us further from the effects of tobacco use. So whilst we do counsel and try and do individual public education interventions so that people in the first place don't start smoking, and to support persons who quit, we've put in this policy as well and working on this comprehensive policy so that we have full protection of people in Jamaica. Then the other area we have been working on, both in Jamaica and globally, is around ensuring that you know what's in your food. So we're doing our education, advising you to go out, buy these foods low in salt, low in fat, unprocessed foods, the right foods, and to select them. But you need to know from a policy point of view, we want to make that choice an easier choice. So we've been working on advancing, having these front of pack nutrition warning labels so that when you go into the store with ease, you can see and make that informed choice. So that's from the population level. And at the individual level, we have our food-based also dietary guidelines, which are encouraging you as to what are the foods that you should be consuming at an individual level. Another area which we're working on is working towards the elimination of trans fats. So we know trans fats are like poison, industrialized trans fats are like poison to the heart. And so we're working on a policy to ensure that in addition to knowing what's in the food and your choices, that we won't have trans fats in our food supply. So we just eliminate that. And we would protect how many people? How many people? Yes, just from that policy. So what we will do at an individual in terms of educating persons, because you need to be aware of what are healthy foods and healthy choices and make an informed choice. But in addition to that, we are also providing that supportive environment. And then to also share that from a population base, we also have our Jamaica Moves program where we're focusing on promoting healthy diets, age-appropriate health checks, and also physical activity. And as mentioned before, exercise, not physical inactivity is the new smoking. We know that physical inactivity impacts on health and well-being, well-established, enough evidence around that. So we have three-pronged approach. And the one that we have built out and we're now heavily focused on for this year is our Know Your Numbers campaign. And that was mentioned earlier. So one thing is to do your, one thing is to know about these conditions, but it's important that persons are screened, persons are tested, but not just being tested, but also to understand what that number means for you. And if you test negative, what you need to do next to prevent yourself from getting these diseases or delaying the onset. So protecting your heart health. And so through the Know Your Numbers campaign, which is a community-based campaign, outreach screening campaign, we are promoting that island-wide and rolling that out island-wide. And it speaks to the blood sugar, it speaks to the blood pressure. Knowing your number speaks to knowing your cholesterol levels. It speaks to knowing also your body mass index, as mentioned earlier. So health screening is also a critical component. And what was also mentioned by our first speaker again was the importance of the fact that persons with lupus interact with the health system. So another component, however, is promoting and integrating and ensuring when you interface with the health system that you do get your health screen. So we can't be treating you for lupus and miss you for another lifestyle-related health condition. And so this integrated approach, we're encouraging both in public and the private setting in terms of how you approach it individual. And one of the areas that we are piloting is a chronic care model for persons with diabetes and hypertension, which would also support managing lupus as well, because really it is a framework for a national framework for chronic care. And we're starting with diabetes and hypertension, but it works with a multidisciplinary team, which is prepared proactive in supporting a patient who is informed and activated. So working together from a patient-centered approach, which is part of our whole strategy towards reform of our primary healthcare system, where the care is centered around the patient themselves. Part of that chronic care model includes a key component, which is self-management. And that is really critical for any chronic care approach. So self-management. So patients interact with their health facility, whether in a public or private setting, maybe every 3 months, maybe less than that, but most of the time they're where? At home in a community. And so because most of the time they're home in a community, we have to empower them to also be able to manage their own illness. So one aspect we're piloting is our national chronic care model, which will help to provide a framework for supporting chronic care. So those are two major programs that we have been involved in both at the individual level and the population level. With respect to the framework that guides this, we have our national strategic plan and roadmap for the prevention and control of NCDs in Jamaica. And whilst explicitly we don't have lupus as a part of that plan, however, this strategy and approach will certainly is focused on heart health, and certainly with a shared risk factor will have the additive benefit. And so thank you. That's my opening remark.
Thank you, Dr. Davidson. I think really very encouraging remarks, and I think making us feel very, what should I say, supported by what the ministry is doing in terms of the various strategies. I always like the point you made about making the healthy choice the easy choice, because we have, we do say to our patients, and we ourselves, as we live in our own, making a choice, we go to the supermarket and we want to do this, but how do I know that this is the healthy one? How do I know that this option is the best one? And what I'm hearing from Dr. Davidson is that there's in part of building that supportive environment, they're helping us to make that healthy choice easier. So we've heard from our 4 panelists, and I want, before we take questions from the wider audience and those online, I wanted to ask one of our persons who's living with lupus, how does all of this sound? What is it? We're talking about lifestyle change, and what is it? What are some of the challenges you face living with lupus? And we're talking about lifestyle change with respect to cardiovascular disease. From what you're hearing so far from the panelists, how does this sound? Is this an easy thing? Is it an uphill battle? What else is needed? So I'm going to invite Ms. Andrea Spence to just share a little bit with us as someone living with lupus and the lifestyle challenges. Just to share a few words.
Thank you. Thank you, Dr. Paul. Good afternoon, everyone. I am a heart patient. My cardiologist, Dr. Victor Elliott, is here today. I had a heart attack in 2012. Subsequently, then I've had to make a lot of lifestyle changes. I'm being guided by all of my doctors, Dr. Elliott, Dr. DeCooler. I had to change the way I eat. I have to read labels, as was mentioned before. I have to ensure that whatever it is that I'm purchasing and consuming is what I'm supposed to eat and consume, as I said, based on the guidelines that I've been given. I also have started my exercise programs over the years. I found, however, that I need to be guided a little more, because just the other day, I did some exercises that did more harm than good. So I know I need to ensure that whatever I'm doing is what I'm supposed to be doing. Somebody else on the panel spoke about managing stress, which is something that, having had lupus for as long as I've had it 24 years. I know that that is something I need to do constantly, manage whatever stressful situation I may face. It is not always easy to do the things that I'm supposed to do, but it is best because I find that I feel healthier, I am more at peace. And so it is something that I encourage all of the other lupus warriors to try to do. Follow the guidelines your doctors have provided, eat what you're supposed to eat, try and exercise, and I'm sure that we'll all be successful at the end of the day. Thank you.
Thank you. Thank you, Ms. Spence. I like how she ended, say, look, follow the guidelines, doctor tell you, eat what you're supposed to eat, and things will work. I recall in practice over the years, telling my patients, here's a guideline sheet, here's what you need to do. And when I look back, most of my patients would say, yes, doc. I kind of have this phenomenon, the yes, doc patients, almost yes, doc, yes, doc, yes, doc. 1 month later, 2 months later, when they're back, you do find when you inquire that they really haven't done this stuff. So you say to them, well, listen, you really need to. hear the guidelines again, say, yes, doc, yes, doc. And that can go on and on. But so there is a challenge to about, what should I say, motivating our patients, getting persons to feel I can do this. And I heard in the panelists, I think all our panelists are talking about communication. Dr. Lawrence Wright spoke about discussion, having this discussion. We heard our nutritionist talking about the value of discussing what's in the tin of sardines. There's not all sardines are the same kind of thing, and so on. So there's a lot of room for communication with patients. Maybe we can say a little bit. I want to invite any of the panelists to talk a little bit. How do we talk with our patients? How do we talk with persons living with lupus and cardiovascular disease to get them to not be the yes doc patients that I know who come back not having done anything? What is their strategy in there somewhere? Anyone? You can use the mic.
Okay, I'll start. Well, for us, we have tools of the trade that we usually use when we're doing nutrition education with our clients. So we want to ensure that they're empowered to make those decisions whenever they're in their homes. So we ensure, for example, that, in terms of the dietary guidance that's given, that they are taught the skills that they will need. So we have our tools like our food models to ensure that, they're actually adhering to they're measuring the foods, they use the equipment, they have their kitchen scale, they have their measuring implement so that they're following, the guidance with respect to portions. In terms of food labels, we actually ensure that they are not just looking at the numbers, but they understand what the numbers mean and what the different nutrients that are listed are and why they're listed. In terms of significant areas in the ingredients list, for example, we actually show them that these are some of the things to look for. So, and we test them. So we ensure that in our interaction, we're not just talking to them, but we're actually talking with them. We're having that conversation. They feel comfortable asking questions. We test them to get the feedback from them to ensure that, they leave us being able to do and not just saying, yes, doc, I understand you, I hear you, I'm going to do it. And of course, there's the follow-up conversation as well to ensure that they are actually following those skills in everyday life.
Right. So there's a need for training, skills development in order to execute.
Yes, that's an important part of it.
Dr. Davidson, you wanted to comment on this, sir? Please send in your questions online, and I will ask in the room if there are any questions in a minute. So, yes, Dr. Davidson.
So what we've found works is generally public education, but education within the health setting as well. We do group education around physical activity, healthy eating, different areas, but also public education within the persons who are living with any NCD. We also do a lot of capacity building. So our organization like this, the Lupus Foundation, you'd build out champions within the group and empower. So the more you see, more persons see persons like them being able to talk comfortably about the disease and advocate about it, then you find it builds a lot of the confidence around this information. We have also most recently started to look at, as a part of our chronic care pilot and other training, is to introduce motivational interviewing, and that's for the healthcare provider. So very often the traditional approach was a very didactic approach, and now we're more of a collaborative approach with the patient in terms of, so you're not speaking at the patient, you're speaking with the patient in terms of what is it, how can you do, and doing incremental steps in order to achieve some of the lifestyle changes, and recognizing that if you fall off, as they say, fall off the ship or the board, that it's not detrimental. you can get back on. So we've been introducing the concept of motivational interview. It was used a lot for HIV in that context, and that is an area that we've introduced with our patients.
Right. Yes, Dr. Wright.
Yeah, thank you. I just wanted to add in terms of the one-on-one patient interaction, I find what I do is I try to have the patient articulate what he or she is doing first. So maybe some general guidelines, but really try to have the patient say what he or she is doing and then identify the gaps in terms of what they're able to express, address the gaps, and then really have the patient articulate the plan. So I can guide the plan, but the patient, I try to have the patient say what it is that they plan to do, identify any barriers to achieving that, address them, acknowledge them. Not every barrier can be removed, but certainly address those that can, and then clearly articulate what the plan is by the next visit. So whether it be in terms of, dietary, physical activity practices, smoking cessation, a definite plan as to, is it going to be 3 times a week, once a week? Is it going to be what? And I say, okay, what is it you said? I'm writing it down. And they see me writing it down, and I said, okay, well, we'll see how you have done by the next visit. And so, it's patient-led. They say what they think they can do. We agree on what we think we're going to, and we document it. And then at the next visit, I can say, and very often what I find, particularly with the smoking cessation, which we know is very difficult, I find that the patient will say they're going to cut down, and very often it's the same because you've written it down, you know exactly what they said the last time. And you're able to say, well, okay, but this is what you said the last time. What are we going to do for the next visit? So I find that helps in terms of moving things along.
Great. Thank you so much. Any questions from the audience online or yes, go ahead.
Yes, I just want to add one of the support tools which we have added. And this, we have evaluated it periodically, and we do need to look at it in more details, is to add what we call a passport. We're actually going to try go towards a mobile passport, but the passport has specific targets around key parameters. So it's to empower the patient to know where they're at and what the targets are, and they can take this with them. We've introduced it also to this program that we've rolled out recently, which is Know Your Numbers, which is a community screening, and that has been very, very popular. I think one of our first event, someone left their passport, which we have created it as like a passport that you're traveling. So you're traveling through the screening village and you have these numbers. And there we have a stoplight system which allows you to see where you fall within your numbers and what you need to do or what's the next step. And that's used as a counseling tool at the end of the screening event. And someone left there and they told them to hold it, and they came back for this passport that they left at the event. But it is a tool to help persons to know, internalize what these numbers are, and then to use that as a next step. And it also helps with also connecting and linking care. But for the patient themselves, is to assist with this whole self-management approach.
Thank you. So we have a question for Dr. Whitebarrow. Do you need a referral to see a dietitian?
For the most part, we have several walk-in clients and we don't turn them away. But ideally, we should use the referral system because the dietitians, the nutritionists who see your patients, they need to know, some of the biomedical details, not just, the fact that please advise this patient on how to eat healthy, which is the kind of vague referral that we've become very used to. But using the referral system lets us, it allows us to know who is really working with this patient. So if we identify possible gaps or we suspect that this patient might be holding back information, we know who to contact.
Right.
With or without the patient's knowledge, and ideally with the patient's knowledge. But yes, the referral system is something that we highly recommend. And if they come without a referral, we usually ask, who's your doctor, who you're working with. what medications you're on, what pharmacists have you been having discussions with. We even sometimes ask about the physiotherapist when we
Yes.
see how some of them walk. But yes,
It's part of the collaboration.
The referral system is what we recommend. But unfortunately, many of them are walk-in clients.
Thank you. So that's promoting the collaboration. We have another question from Amanda King, who says, thank you for an excellent panel. What self-management program are you using? Are there specific tools, models you can share with our patients across the Caribbean? Maybe I know you're just talking about some of that. And you want to add anything more, Dr. Davidson? Or that's yeah?
Just the yes, so we did have a chronic care passport.
And
The back on. Yes, so we do use a chronic care passport. We are currently developing. We are also planning to have a mobile app for patients as well as providers, but mainly focused on patients. And so that is current work. So it is mostly under development with respect to the mobile app, but we have the chronic care passport.
Thank you. I see Dr. Tullereed in the room has a question. Professor Marshall Tullereed. Go ahead, Prof.
We're talking as health professionals at a completely different level to what patients understand. There's like a lot of jargon. We're saying cholesterol is high and their blood pressure, but we don't try to understand what people are internalizing when you're here. You say, so they say, no, you're no worse, and the blood pressure is high. What's it? It's not probably anthropological or things from physical. So physical effect is expected for illness, and physical effects is expected for medication to show effective. I don't know if there are any thoughts about going back to trying to understand a little bit more about how people are interpreting and understanding things so they're trying to communicate. If there are ways that they should be communicating which are more effective. And then the second part of the question is also related to how patients relate to different members of the health team. So I could speak to the patient and we could have a long conversation, and it's not as effective as if the nurse speaks to the patient or another member of the health team speaks to the patient. And the challenge that we're having now with gaps in a number of those other members of the team, because direct nutritionists in the health system, so there's a lot of nutrition counseling, and if they are accessible, that would be challenging. The absence or shortage of nurses, primary care settings, the distressing, so they have no time to anything outside of just the basics. I don't know if there are any strategies that I can speak about. One, to understand how to make it better and to address some of the critical gaps in our healthcare system, which could impact our ability to promote and support lifestyle change.
Davidson, you take that?
Yes, I just want to say that's an excellent point. And in fact, coming out of some of our audits we've done, there is a patient exit interview. So patients will tell you, I'm supposed to eat more, be more physically active, but they really don't understand their disease or what, when you use the concept of diabetes, what it means. And we do need to have communicate better with our patients. However, we found also that some of the gatekeepers are not even the nurses or the doctor. And based on even my personal experience, very often it may be an orderly or a community health aide. So when they leave your office and you have explained something to the patient, they come out with the information and ask, okay, please explain what doctor said, and it's orderly that's there. So one of the strategies is, and we're going to be doing quite a bit of training and retraining, is also about really looking at our communication skills, but a team approach. So when you're doing training, and the team approach should include right down to the orderly and the security guard as part of that whole team. If you're looking at primary care, you cannot. So we know we have gaps with respect to our professionals, and that's another area that the Ministry of Health is working on, but also looking at task shifting as well, and a variety of new and other professionals to make up that team. But if we work with a team approach and not just looking at our professionals, even our allied professionals, we need to include everyone, because you're coming out, giving the patient, even if the patient understands, once they leave your office, and if that orderly or that attendant tells them otherwise, that can just kill your whole program. And we've found also very effective community health aides. So they're pretty effective in taking your instructions, translating that for the patient, and in fact, getting the patient in to care. And I've seen it happen repeatedly over and over again. Because sometimes the patients, the way we, in a rapid, quick, short session, and even how we articulate, and we use all of these jargons that you said. And I think it also needs to go back to medical school too, in teaching or professions or medical school, whether it be other professional schools, how to communicate in a way. So usually, if you look at the rule of communication, you should be producing materials that are at, I think, grade 5 literacy level. And so health literacy is a big area that we are working on, recognizing that this is a major gap. So we're not there yet, but I think there are multiple strategies to do that, because even the items, the brochures, which tend to be quite verbose with all of these different languages that people don't understand, we really need to apply some of these health promotion principles and health literacy approaches.
Yes, Dr. Davis. Thank you. Thanks, Dr. Davis.
Stacey, sorry, Stacey.
I should be moving more, but so, Dr. Davidson, as you brought up the issue of health literacy, one of the concerns I have practicing in Jamaica is I think our society is not socialized for our patients to understand health on a whole. And I don't think sometimes they want to be bad patients. I think they just don't understand, right? And I was wondering, with all of these great programs that are coming out to the Ministry of Health, is there anything that targets, even from primary prep school, understanding health, understanding the stages of life, understanding that you likely will develop something, because coping skills is also a big issue I find here, comparative to when I practice elsewhere. Our ability to comfortably adjust to having issues arising in our health, we seem to have challenges with that. I didn't know if there was any crosstalk between the Ministry of Health and the Ministry of Education. We hear about education being revamped and putting back civics into our schools. Is there something to help our population socialize them during the developmental stages in understanding health better, right? And health not being the last thing. Because the other thing I get from my lovely patients is the cat broke a nail, the car got a scratch, I went on a great vacation, and hi, Dr. Davis, I'm back after 2 years to deal with my health. It's almost like the last priority that many of our patients deal with, not because they, I think, want to be bad patients, they just don't get it.
Yes, so there is actually a program, and we do work, the Jamaica Moves in Schools. Well, we have Jamaica Moves in Schools, workplace and community setting. But even outside of that, you have your health and family life curriculum program, which is actually a Caribbean-wide program. It's becoming, I would say it's institutionalized in the Ministry of Education, and that's where a lot of the health information and priority around nutrition and other areas, substance use, occurs within that particular curriculum, where they now have teachers, persons dedicated now to, deliver that particular content. But that has been a process over time, but we do work very closely with Ministry of Education around that topic and other areas as well. With respect to, you see, the challenges with NCDs is very insidious, creeps up on you, feel well for a very long, long time. And so many patient persons, even if they know, even healthcare providers, I'm sure if we do a study amongst healthcare providers, maybe our practice would not be even as good as some of our patients, even knowing what we know. Because of its insidious nature, it's something that people put away for another day. I'll say, okay, yeah, next year, 2 years, I'm feeling well. So I really don't need to deal with this at this point in time because I have time. So that's another component of it. And then, of course, we've talked about the mental health component. Once you get a diagnosis, people go through the stages of grieving, like with any other illness. And we talk a lot, we did a lot about HIV and AIDS, but many of the NCDs, it's the same reaction. We, even for persons to even share in a public space, there's a lot of stigma around even sharing information in a public space. So sometimes the behavior also is not just lack of knowledge, but also a lack of acceptance of a diagnosis, which is a lifetime diagnosis as well.
Ms. Hosan wants to add to that.
Sort of also to go back to Prof. Toller Reid's question about, patients sort of understanding, remembering the jargon and so on. What I've experienced as a physiotherapist over the years is that I think sometimes time is a huge factor. And by that, I mean, doctors, how long do you get with your patient, whether by choice or by the design of the system you work in? Maybe 15 minutes, maybe half an hour. Physiotherapists, on the other hand, may get a minimum of half an hour, going up to an hour. And so what we get is, we get the person who has been referred from the doctor, may have had their condition, their disease for many years, or it's a new diagnosis, but we are the ones getting all the questions and what does this mean? And why did doc give me this prescription? And I really have to fill this, and why I feel this way, and why my head hurting me, and all of this. And really and truly, it's a lot about time, because you guys probably don't have the time to sit there for an hour with every single patient to explain. And the other thing to remember is that you wouldn't expect a child in school to learn something in the first lesson. There's a reason we teach things over and over and over, and then we do an exam at the end of the term or the end of the year. And I get it all the time when I work in chronic pain clinics. Even in England, you think it's going to be different. It's England, free education, free healthcare. It's just the same. They don't remember anything. They don't understand anything. They're in denial. You have to explain over and over and over and over why they have chronic pain, what chronic pain is. They're frustrated 10 years after they've been to every consultant under the sun. And part of it is an intellectual ability to receive and process the information, as well as the other factors that go along with, healthcare decisions and choices and so on. So I think give yourself some grace as physicians. It's frustrating for us too as physios, because I've had people come to me and ask me about why they have a sexually transmitted infection. And I'm just like, not for me. But I've had to sit there and counsel people about risky behavior for STIs. I was like 2 years out of physio school. So they come to us because we have the time to sit with them, because a physio session is going to last 45 minutes. So they just push everything in there. They get all their healthcare needs met at physio. So give yourselves some grace as doctors, but also be patient with the patients. because, they're not doctors, they're not healthcare professionals. They're not going to remember everything that you say in a 20-minute session. I go to the doctor, convince myself I know everything the doctor has just said, get my prescription. By the time I reach to the pharmacy, I'm looking at the prescription going, what she said, which one must go first? Which one I have to eat food? I'm a patient. I'm not a healthcare professional in that moment. So part of it is a learning thing as well.
Yeah. So talking about time, we're gonna have to wrap up our session fairly soon. Dr. Right, Lawrence, you wanted to say something as a last point?
Well, I was just going to say a very quick thing in terms of just remembering the value of the patient's voice. Because I think one of the things that Dr. Navarro Milan had said this morning was just with her program of peer coaching. And, patients may need to be coached and properly, educated to be able to communicate properly. But, they may be able to reach that patient more than any one of us who is a professional can. And we just need to provide the forum for them to have these discussions with the patient support groups or whatever it is. Because it may be that conversation makes more of an impact than any one of us could in our professional capacity.
Indeed. Yes. Okay. So I think we have a line.
Yes, we've been waiting.
All right, so let's.
Okay. Hi, I'm Dr. Elliott. And again, I commend the panel for a lot of what you said. And I thank Andrea, my patient. She has really done well. We talk about cardiovascular disease with lupus, and I would say she's a model patient. Let me commend her. She has followed the instructions, and her heart health has remained quite well as she has gone through. Oh gosh, you guys have touched on so many things that we could spend all day here. But I just want to ask one direct question and just one line of promotion. You talk about nutrition, fiber and so on. One of the problems I've had with patients, I just want you to just explain fruits. Now, I've had patients who just believe because they're eating fruits, they're the healthiest diet. And I know Marshall can, the diabetics, like I had a diabetic with their A1C is 11. And I said, Doc, all I eat is fruit, 3 bananas a day, 2 pineapples. And I'm like, that's why your sugar is high. It's true, But just give a practical thing in terms of really the role of fruits in the setting of a healthy diet for your lupus patient. And the last line, just a promotion for everybody who's here. Before you leave, come for your fridge magnet and your flyer and your bag by the PICJ stand.
Thank you, Dr. Elliott. All right, fruits. So in the Caribbean, we're blessed with a variety of fruits, but we recognize that some fruits, putting it simply, are sweeter than others. And especially as they ripen, even some of our less sweet fruits, like if you think of June plum and apples, for example, some varieties as they ripen, you find that they will cause your blood sugar levels to rise. So what we usually use as a guideline for those fruits that are ripe, for those fruits that are sweet, those are the ones that you should have not as frequently as the other fruits that are less ripened, because it means that the level of simple sugar, so you're talking about the glucose and the fructose, those will not reach your blood as quickly from the moderately ripened fruits. Fruits like your star fruit, for example, as they ripen, that the sucrose content will get higher. But they're all rich in fiber. So it's really the sweetness that cues you into the fact that this particular fruit is going to cause my blood sugar level to go up quickly. We also find, apart from the sugars, there is also the antioxidant value of your various fruits. So you know that those brightly colored fruits that have the red colors, the orange colors, the yellows, those will tell you that there are high levels of antioxidants in these fruits. The vitamin A's are present. The more acidic your fruit, it tells you that this particular fruit has a lot more vitamin C, which is also important. So those are the simple guidelines I would give you in terms of your blood sugar. And, you know, for the lupus patients who are looking for more antioxidants, you know, you just eat a variety of fruits. And if you can adhere to the guidelines, you know, to have the 5 recommended per day, because we know that, you know, the more variety that you have and the more fruits you eat, it will help you to get more antioxidants in your diet, which have a variety of benefits. And then, of course, there's the fiber, which is highly beneficial.
Thank you. Thanks. Dr. Tollerine, you have a question?
Just jumping in quickly, because I won't be able to ask all the questions I wanted, but I really want to thank all of the panelists for really addressing so many critical factors. And my 2 questions relate to, anybody can answer, but I am picking up on this, the power of the group. I heard Stacey's comments and I heard some comments before and Prof's comments, and I thought sometimes we believe that we're the center of the patient's lives, but we're not. And so that's why we talk about patient-centered care. And they're talking about all these other things that are part of the social determinants of health. So maybe we need to engage a little more about those things as well, and our role, the power that we have as physicians in terms of, showing what's important. So if we don't talk about those things, then they may not think they're important, and just spinning over into the role of our allied professionals, because I also observe the same patient avoidance, not realizing the value. And I think one thing we're learning here is that there is a lot to learn that the physician cannot give you. And I also really want to appreciate that the power of the group. So this is where we come in, Lupus Foundation. And I think perhaps, I don't know if in the area of nutrition or physiotherapy, or anybody's looking at the possibility of group sessions. Sometimes I see that kind of dynamic happening at KPH, where they sometimes call the patients over for a special day or something, but that could be one way to deal with the racial issue and also harness the power of the peer group in reinforcement. And certainly in Lupus Foundation, we have seen the power of that group and engaging, even having this kind of shared space outside of the formality of a direct doctor-patient relationship. We can have even health professionals sharing the space, but allowing the peer. And in fact, as I heard Dr. Davidson, we are so grateful for the support of Ministry of Health for lupus patients, because a lot of money is being spent on their treatment. And even though we heard about the essential 8, we know that in cardiovascular disease, we have, maybe we should call it essential 10. I don't know if I'm using the right term, because we know that lupus control is a critical factor and they're able to access those treatments. But I wanted to say to Dr. Davidson that when you said that we're not a part of your chronic disease plan, we are, because when we looked at we see that happening, because when we looked at the development goals, as we were submitting for a subvention application this year, we looked at the development goals and we were excited to see that we fall squarely into the agenda of the ministry in terms of its goal of engaging these community-based groups and these associations. And so we're looking forward to further partnership. We start our peer support program, training program, hopefully next year, God willing. And we're looking forward to more partnership so that we can have that bilateral engagement. So thanks for letting me make those comments. I had actually a question, and it was just about, is there a conversation happening about things outside of the ministry that may influence people's lifestyle? The form equals function in societies where you have sidewalks and where, their bicycle lanes or public transportation is used more. Are we seeing that? Are we seeing where there's a benefit to that? And is there any other cooperation with other branches of government to make sure that happens.
Thanks for that. So just to explicit say that to qualify that we haven't explicitly stated, yes, that we're addressing lupus in the plan explicitly. So I threw that out, but certainly the overall strategy and framework is inclusive. With respect to the multi-sectoral plans, yes, we have been working with different sectors. We do have our National Committee on Non-Communicable Diseases, which is a multi-sectoral approach, which translates to working with different government departments and agencies, also with NGOs as well, around addressing the risk factors for NCDs. The ones we mentioned from a policy point of view would need to be, most of the actions are outside of health. So with respect to the Road Traffic Act, for example, that governs a lot of the roads and sidewalks, etc., and cycle lanes. So we are working with different government agencies. Our focus has been primarily around the nutrition and certainly physical activity as two critical components, and tobacco and alcohol as well.
Thanks much. I think I know Dr. Tollery gave a good summary in a sense of where the panel has been. We'll take one short question. We have someone at the mic, so just a quick question.
Good afternoon. I'm Dr. Morgan. I work in the Accident and Emergency Department at UE. Quick question for Dr. Davidson. You mentioned motivational interviewing. Is there a short version, something that I can use to help motivate patients that come in with the emergencies of their illnesses, to just try and motivate them to actually take care of themselves so that they don't have to see me?
What I would say, there's an introductory course that helps you to just reframe how you speak with the patient. And yes, and it can be done in an A&E setting, but what it's doing is just retraining you how you speak and engage with a patient. We are working with a consultant on advancing that process. The work was done on the HIV. So if you're interested, we can certainly link you to probably doing some sessions. It does require a training session with the teams to do that. And it's quite useful in any setting, even outside of health. It's used pretty frequently.
Thanks much. Our final question, which is an online one too, and this goes to Ms. Osang. Is there any best exercise, and is it age-related, for heart health and maintaining muscle mass? In a nutshell. Yeah.
In a nutshell, any exercise is better than no exercise. And I would say for the general, everybody in the population, let's focus on the aerobic or cardiovascular exercise, certainly as your beginning point. But you don't want to forget your strength training, especially as we get, for females, especially we have to think about the hormonal changes and osteoporotic risk, and also just the elderly in general need to be doing the strength training as well to maintain the muscle strength and the bone density and so on. But you really need both, generally speaking, your aerobic for your fitness and your endurance, and your strength training to maintain that functional power, that ability to do things, to lift things, to move things, and so on. Children don't have to worry about strength so much, but they need to be allowed to play and run up and down.
Thanks very much, Ms. Hosang. So this panel, colleagues, was about what should we do? That was the question. What should we do? The lifestyle factor and collaborative approaches. And I think, as you heard from Dr. Tollery, that she summed up, I think, quite well a while ago, we have had a very healthy discussion. There's a lot more. We have started the discussion. There's a lot more that we need to take on and expand on and build. But we feel very, heartened and encouraged that there's a lot happening already, both at the patient care level with physicians, health providers, or allied health providers, and at the macro level, at the institutional level, with the role of government and partnerships. So I think coming out of the panel, we're hearing some kind of themes that come out. We pay attention to context. We hear about that with our diet, where we live, our context or situation, how we communicate, the value and the importance of communication. But we need to look at that again in depth and more strategically so we can have meaningful communication and impact. And the last C is collaboration. And that collaboration that we hear about the role of government. A lot is happening coming out of the ministry in terms of strategies and approaches to improve impact of the non-communicable diseases, including lupus. And we certainly will continue to look forward to building out that team approach. So context, communication, collaboration are key themes that are coming out of this panel. I want to thank all the presenters. Let's just give them a round of applause for their contributions, taking the time to come and share with us. And I want to thank you as the audience and our online audience for staying with us. Thank you very much. Back to our chair. I think at this point, Mr. Pete, Mr. Smith.
Thank you. Might I ask the panel to please remain seated for me? Includes you, Dr. Tomlin. Paul? It might be a rhetorical question, but did we get to the heart of the matter? Indeed, I think we did. And I certainly believe that the whole matter of cardiovascular health and lupus was widely explored and deeply delved into in a way that it could be interpreted at a simple level and certainly at a relatively high level, because there are many things that went over my head as well. But I believe it was adequately balanced, the presentations at the symposium today. So my task at this time is to give a vote of thanks. But before I go to the vote of thanks, I'd like to invite Ms. Mildred Marsh, one of our lupus warriors, to assist me with the presentations to our most esteemed panelists. Mildred. And Shauna, would you care to assist Abayumi? I'd really be grateful if you'd help as well. They're all on it, right? Somebody name? I'll call it. Dr. Tamu Davidson, will you join us here, please? So. Just a moment. Can I ask you to please, my photographer? Yes. Thank you very much, Dr. Davidson. Thank you very much, Mildred. And why is Mildred gone so quickly? Not finished with you yet. It's not right there for me. Dr. Cecile Hosang. Miss Cecile Hosang. Thank you very much.
All your hard work. We appreciate you so much. Thank you. Thank you. This is for you. Just a little gift of thanks. Appreciate you. Appreciate that. All right. Good.
Thank you, Cecile. Dr. Vanessa White Barrow, would you kindly join us, please?
Okay. Thank you very much.
Thank you, Dr. Barrow. So you see the last. Anyway, Dr. Tomlin Paul.
Dr. Paul, on behalf of the foundation, we can use the presentation.
Thank you, Dr. Paul. The last, but definitely not least, Dr. Marilyn Lawrence Wright. Can I ask you to put some thought on the screen? Thank you very much. You know, it's an interesting segue for me to really thank all the volunteers that are here this evening. I'd like to thank, of course, Ms. Forbes, Ms. Kimberly Forbes. You've done a wonderful job so far. Shauna, I know Cedric is not here, but I'd like to thank him as well in absentia. I'd like to also thank Sybil. She may not be hearing me because she may be outside, but Sybil McLean, one of the members of our team. Asta Prendergast, hey, thank you very much. Right. Moses, Wasio, thank you very much. Much appreciated, you know. Jehovah, respect, sir. Thank you very much as well. The AV team, this is the technical team. Without you, nothing happens. Thank you very, very much. I'd like to thank as well my photographer, Dean Hugh Thompson. I don't think he missed a beat. I think he caught us about everybody. Thank you very much, sir. I'd like to thank as well Omar Oliphant. He's not here, but he was a pastor who actually started us off with a very inspiring prayer and message, which really got us kicked off on a very good note. I'd like to thank Pastor Oliphant, and certainly we roll into a very good spirit from there. Our moderators, I thank them very much. I'd like to thank specifically Dr. Stacey Davis. I'd like to thank and it's interesting that I just called Dr. Stacey Davis's name because I'd like to invite her to the lecture. Dr. Davis would like to thank you, but Abayumi will be even more personal in her comments. Thank you very much, Dr. Davis. Other moderators I'd like to thank includes Dr. Asana Anderson, Dr. Caroline Hagley. Thank you very much. And of course, Dr. Tomlin Paul and his wonderful and most articulate panelists, which I think we couldn't have had a more qualified panelist that spoke about patient care in such a sensitized way. And I think the motto was, it certainly resonated with me, and I certainly hope it resonated with all the persons here and those persons in Zoom and in Facebook, as the case may be. Thank you very much. I think the discussion was rich, and I think that everybody would have a takeaway from this evening. I know that getting up and walking around is going to be certainly one thing I'll be doing more. Okay, 3 and 4 bananas, like but I go there. I didn't want to throw my question about bioengineered food or GMOs, but Dr. Davidson, we'll have that conversation at another time. Ooh, you passed on to her, okay. But those are some of the things I think we got to be sort of careful of in terms of labeling. But I was very impressed with the contribution of each of the panelists. I thank you very much. Our sponsors, without them, we would have had none of this event. Partners Interventional Center of Jamaica, Partners Interventional Center of Jamaica. I'd like to thank them very much. I'd like to thank Wisynco, whose brand of water is sort of flowing through here, even though we shouldn't be drinking it inside. National Health Fund and the Ministry of Health. They've been doing a wonderful job in getting medication at a more accessible and more affordable to our lupus warriors. I'd like to thank as well Medical Products Limited, IPCA Laboratories, and the Barita Foundation. Thank you very much, all our sponsors. Dr. Elliott, your team was wonderful. I thought that video was excellent as well when I saw earlier this morning. You're a part of my social media team. Clearly you are, and I see you've made sure that everything was caught. Thank you very much. I don't think I got your name though. Kian McCoy, thank you very much. I'd like to intro, I know the names. Thank you. A special thanks definitely has to go to, right, a special thanks has to go to a special Tullereed here. I know Marshall Tullereed is a great guy and also from good lineage, but I'd like to thank, of course, Dr. Desiree Tullereed. But nevertheless, I'm going to leave my comments to Dr. Desiree Tullereed towards the end. But right, I would want to ensure that all persons here as well as in Zoom are fully aware and are fully as appreciative as I am of our very many sponsors, starting with our list of platinum sponsors. Of course, there's Partners Interventional Center of Jamaica. There's Wisinco, the producers of water, WATA, and the Crown Water. The gold sponsors include the National Health Fund, Medical Products Limited, IPCA Laboratories, the Barita Foundation. We'd like to thank Tuwani Limited, members of our silver sponsors, Phoenix Gastroenterology and Health Services, the National Housing Trust, and Proven. Our bronze sponsors included Ligany Drug and Garden, Popeyes Restaurant, Popeyes Limited, under the banner Restaurants Associates Limited, JMMB Loan Foundation, JMMB, the Joan Duncan Foundation, apologies, Collaborative Care Internal Medicine, Morgan's Creek, Indies Pharma, Jamaica Teas, the Rapid Relief Team, Imagination, and Yorkali, not here today, but I'd like to thank him as well, Co-Create Caribbean, the Heart Institute of the Caribbean, at the heart of the matter. Wow. And of course, Grace Foods and Services, the big team AV Concepts, yeah. Sleek Jamaica Limited. Oh, I'm not with AV Concepts, just in case you all thought so. But very good team. Sleek, and of course, Flo, who has been a partner with the Lupus Foundation of Jamaica for quite a few years. I'd like to thank all these sponsors and recognize them for their assistance and their continued support to the Lupus Foundation over the years. Our Lupus warriors who are extremely brave and resilient and continue to fight. As the saying goes, loop us, together we're stronger, and together we will make a difference. We will succeed. Mildred and family, thank you very much for being here. Asa Prendergast, I see the family is there as well. Always, thank you very much. Thank you very much, Dr. Desiree Tullereed. Marshall, I'm happy that you're here to keep her, sort of grounded. But I thank all the persons who are here physically and all the persons that have been here online, on Zoom, on Facebook, and on YouTube. Because I've had a few friends calling me saying that, boy, Pete, is it still on? And I text them, say that, oh, yes, you're going to get an excellent section with a panelist. So that was like about 1:32. So they all tuned in, and I'm sure that they were just as grateful for the information that was imparted. So, ladies and gentlemen, it is now for me to say thank you once more again for attending. Have yourself a very good rest of the Sunday afternoon. Drive home safely and Godspeed. God bless you all. Around and get a chance to meet everybody. I just invite you again to stop by the booths. The Lupus Foundation booth is there. The Partners Interventional Center of Jamaica. The booth is also there. The Lupus booth, where you can get items on Lupus Foundation and the work that we're doing, inclusive of the various ways in which you can make donations and just to be a part of that community. All right, please feel free to stop by and thanks again.